Good evening, faculties members. Good evening, delegates and participants. Thank you for joining Shield Connect. And we are back with the series. And this is the webinar on understanding the placental issues. It is sponsored by Haryana Association of Obstetrics and Gynecology. And the organization is done by help of Dr. Varsha Bastine. So before we start with the session, let me introduce Dr. Jyoti Malik ma'am. Please flash the CV, Eva. Dr. Jyoti Malik ma'am is a medical superintendent in JJ Institute of Medical Science, Bahadurgarh. Ma'am is director of Roots IVF and Fertility Institute of JJIMS and Secretary General of Haryana chapter of Indian Society. Okay. So now I will hand over the session to George. Okay. And ma'am is also Secretary of Haryana Association of Registered
Hand over the session to me. Thank you.
Okay, ma'am. Okay, ma'am. So I hand over the session to you. Thank you, ma'am.
Thank you. So thank you so much, Shield. And I think Sahiti Priya is not here. So she has been doing a lot, coordinating the whole show.
Yes, ma'am.
And I would like to thank her of Gyn to have given us this opportunity to be here on this platform. So to begin with, I would like to introduce our president of her of Gyn. May I have her CV, please? And she is the chief guest today, our own Dr. Ragini Agarwal. Dr. Ragini needs no introduction. We know that she is, her CVs, I mean, if I read out this CV, it will take me another 20 minutes. And ma'am has done so much for Haryana, so much for our fellow gynecologists that it is, she is the true leader in the sense, in the true sense of being a leader. Yes. She has so many social commitments, so many awards, and she is the founder of, to be brief, she is the founder of Her of Gyn and has been the vice president of FOGSI 2020. So, ma'am, I would just take your blessings and I will utilize this time taking your blessings.
Thank you, Jyoti. Thank you so much for your comforts. Very good evening to all of you. Varsha, we call her the beauty queen of the FOGSI. Welcome, Varsha, to Haryana and our best wishes for your coming elections.
Namaste, madam. Thank you so much.
One word about the Varsha. Varsha is not only a doctor. She is well versed in every aspect. You ask anything from the beauty to philosophy to spiritual music, she has a detailed answer for everything. I am a person who doesn't know much about anything. I never know there's something called odd as a ascent. She educated me for that odd also and given me a little bit odd also. Okay. So this is the Varsha. And now coming to this topic. Today's topic is on the placenta, and we all know that the placenta is the biggest endocrine organ in our body, and it is one of the things which can take the life of the patient also and life of the doctor. It is very necessary to understand all nuances, and I know the great faculty is there. I will not take the name of everyone because the delegates are sitting to listen here and learn from you. The only one line I want placenta, any time the anterior placenta is cesarean section or not, if anterior lower placenta previa, always have on alert, and if there's a cesarean section, your ultrasound is saying there's an interface is there, even keep alert. Maybe a part is maybe as a beta. At that time, you will be really in problem. There are 2 or 3 cases are going on in medical legally where a patient is died because of the not diagnosing placenta in beta in time. So please listen very carefully to this panel and understand the placenta properly. Thank you so much. Happy learning.
Thank you, ma'am. Thank you for your absolute crisp and clear messages to us. And I'm sure we would also be taking your expert comments in between if you are there logged in till the last with our panel. Can I have the CV of Dr. Varsha ma'am now? Please, can I have CVs now? So, as described by Dr. Ragini ma'am, Dr. Varsha is a multifaceted person. I mean, you talk about perfumes, you talk about diamonds, you talk about religion, you talk about meditation, you talk about obs gynae, you talk about anything on this earth, and Dr. Varsha has the answer for that. So she is a person, she's an encyclopedia of everything, and I really don't know from where she gets so much of knowledge. So that was her personal front. I would read out her CV very briefly and quickly. She has been practicing in Nashik for last 30 years. She is director Pushpa Fertility and Baste Maternity Hospital. And she, in 2003, delivered the first ICSI and PGD baby in North Maharashtra. 2014, she was the past OB-GYN Society president of Nashik and was a chairperson of FOGSI IAEC, so International Academic Exchange Committee. 3 years she has done so much for this committee, and the amount of international speakers that she brought. And during this time also there was COVID, so there were so many webinars that she also with the foreign faculty that she did. It was unimaginable, the work she has done during her tenure of these 3 years. It was really fascinating. She has been awarded the prestigious Dr. Anandi Bai Joshi Award, and by V for Istri Amogh's Puraskar has been given to her by Honorary Governor of Maharashtra. She has bagged the Champions of FOGSI Award and FOGSI Excellence Award for the outgoing FOGSI chairperson. She has organized many national, international conferences and participated in more than, I don't know, I mean, she might have lost the count as well, how many conferences she has participated all over national and international. She is founder member of MSR, Maharashtra ISAR, and life member of many, many organizations. And actually today's webinar has been actually planned out and is sort of dedicated to Dr. Varsha Baste, because she takes a keen interest in reducing the maternal mortality throughout anywhere in India. So I welcome Dr. Varsha Baste, and I also invite you to say a few words and thank our chief guest.
Thank you so much I'm really overwhelmed by the sweet and kind gesture shown by Dr. Ragini Agarwal and Dr. Jyoti Malik, my mentors, my close friends. All are my close friends, but they are one of them. And I'm really thrilled and happy and very excited to be amongst with you all, because when I told Jyoti and Ragini, they said we will have a webinar, Haryana ka webinar karate, and Haryana ki Rani hai Ragini Agarwal. So I'm so much blessed with such a lovely and such generous and so kind and genuine friends and leaders also. They do not think of appreciating anybody. They will see only good things in everybody, and they will make you feel special. That is what I'm feeling today. So I'm really thankful to all of you to be here who have accepted the invitation. And I would like to say thank you to the chief guest, Dr. Ragini Agarwal. Her towering personality speaks a lot volumes, and she has really done such a good work for Haryana, and significantly Haryana OBGYN Association has marked their presence in FOGSI, and we have another Thank you, Ragini Agarwal, for sparing your time and coming over here. Dr. Vandana Punia, the Dean of the Medical Science and Technology in the University. So I would like her to be, I cannot see her here, but I'm really thankful to her to have joined, and Dr. Viba Dua, Senior Vice President of the Haryana OBGYN Society. I'm really thankful for your presence over here, and these esteemed people have increased the standard of this webinar, no doubt about it. Now, I'm really thankful to Dr. The speakers, Ruby Bhatia, Richa Kansal, me, and the chairperson, Mitra Saxena, Renu Chok, Poonam Lomba, Aarti Kaushal, and our my co-chairperson, my co-moderator for the panel, Dr. Savita Rani Singhal, who have painstakingly prepared the panel, and she is so generous. She said, I will do it, you don't worry, and we just discussed few points, and she has really painstakingly prepared this great academic panel discussion. And we have a esteemed panelists, Promila Malik, Ritu Jain, Priyanka Singh, Raju Mahendru, Jyoti Malik, Shashi Kabra, all my great friends, and Monica Dalal. So with this brief introduction, I would like Dr. Jyoti Malik to start the academic session, and really thankful to all of you from the bottom of my heart. You have spared such an important time of your life and given it to this webinar. I'm really blessed. Thank you. Thank you so much.
Thank you so much. Thank you, Dr. Varsha. And may I have, we have our guests of honor, Dr. Vanna Punia. Is Dr. Vanna Punia there? Can I have a CV in the meantime? And if Dr. Vanna Punia is there, we would like...
I think.
Okay. So we will take, as soon as she joins, we'll ask, we'll take her blessings as well. And Dr. Vibha Dua. Dr. Vibha is the Senior Vice President of Her Obgyn. If Dr. Vibha is there, we can... Dr. Vibha is a life member of Her Obgyn, IMA, FOGSI, a senior obstetrician gynecologist working in Sonipat, and she is also the Senior Vice President of Her Obgyn. Dr. Vibha, if you are, have you logged in? No. So straight away, I think we go on to the first scientific talk. Next, please. Next, please. So can we have the chairpersons for the next talk? Can you
Deva,
please
please
display
share
the
the CV.
program?
Dr. Mitra Saxena.
Yeah. So we have Dr. Mitra and Dr. Renu Chog, who are our chairpersons for this first topic, the first topic that we have on the, this is the topic 2, we have topic 1. Can you please display that? And I would invite our chairpersons. Yeah. So we have Dr. Mitra Saxena is the chairperson of Practical Obs and Gynae Committee, and she is also the convener and project director of Mukti, which is one of the projects of Her Obgyn. She is a very senior consultant practicing in Rivari. And if Dr. Mitra is there, because she was to board a flight, if Dr. Mitra, can you, if you are there, can you just start the session if you're there?
I think she's not available because just now we cannot see her. Till now she was here, but now she is not there.
Okay, so we have Dr. Renu Chog. Dr. Renu Chog is another very senior practitioner at Bhiwani, and she is also the president of FOGSI Bhiwani. She was in 2021. She is President Haryana ISAR, and she is the recipient of Rashtriya Gaurav. And I give over to Dr. Renu Chog to introduce our speaker for the first talk and the topic, please. Dr. Renu, please.
Good evening, everyone.
Namaste, Renu ji.
Yeah, namaste. Kaise hain? How are you? Everybody fine?
Maze mein.
Yeah.
Beautiful personality you have.
Okay,
All right.
thank you. Can I have the series of Dr. Ruby? Okay. So today we are going to start our webinar with the first topic of all about placenta. And for this, we have with us Dr. Ruby Bhatia, who is MD FICOG, Professor and Head MMI MSR Mulana Ambala. She is a fellow Indian College of Obstetrics Gynecology, ex-professor GMC Patiala, Punjab, master trainer, training medical offices, trainer of trainees, UMC Punjab, ex-in charge of STI program, Department of OBG Gyne Patiala, ex-supervisor, RTI, I think long CV. So maybe I think everybody can just go through and areas of
It's a
interest.
webinar itself.
Yeah, I'll highlight about her areas of interest. They are not like so.
I think ma'am can
Menopausal
start.
health.
Yeah.
High risk
It's not
pregnancy,
good.
adolescent and
Yeah,
menopausal.
high risk pregnancy, adolescent, and menopausal health. So,
Thank you.
Dr. Ruby is going to tell us about placenta. To look at placenta seems to be very basic topic, but it's very important for the fetus, and many complications and I mean odds and positive things, they are connected with placenta.
Yeah.
So I think we should have a basic knowledge to deal all these complications. So I invite Dr. Ruby to go ahead with your talk today. Thank you very much.
Namaste, Dr. Ruby
Good
Bhatia ji.
morning.
Thank you so
Good
much.
morning, everyone. Good
Good
morning,
morning.
Good
Dr.
afternoon,
Ragini,
good
Dr.
evening,
Good
whatever it
morning.
is.
Good evening,
and
good
morning.
Dr. Renu. Kindly bear with my bad throat and fever. But since it was scheduled, so I have to give the lecture. This is really,
nice,
you
so
have really
nice of you.
chosen the topic very wisely, because we just are bothered about the baby. We hardly talk about the placenta.
Yeah.
But how important it is, we all will do what we all should know about the normal placenta. So as we all know, human placenta is a circular cake. It is hemoporial. It is discoid. It is deciduate. The placenta is a fetal organ. It consists of umbilical cord, membranes, that is chorion and amnion, and parenchyma. So all these together form the placenta. And the beauty is that it affects and reflects both maternal and fetal well-being. Visual placental examination by obstetrician is a must-do in delivery room, whether you are doing a vaginal delivery or a cesarean section, which is often missed. Routine pathological examination is not indicated unless there is a special indication. However, whenever there is a fetal or neonatal death, it is the placental examination, pathology examination is an essential component of the autopsy. Placenta is indispensable interface between mother and fetus. So as in when we do prenatal ultrasounds, we always identify and record placental location, and also see what is its relation to the internal cervical os. So it is on the very first NT-NB scan, we see where is the placenta. And it is homogeneous. The average thickness is 2.5 centimeter. It lies against myometrium, and it indents on the other side the amniotic cavity. The retroplacental space between the placenta and myometrium is never more than 1 to 2 centimeters. A little few words about the development of the placenta. Now, on the post-fertilization day 4 and 5, the blastocyst formed is 58 cells. The 5 cells, they form the inner cell mass, while the rest of the 53 outer cells form trophoectoderm or trophoblast, which forms the placenta. So trophoectoderm on day 5 of the fertilization, and on day 8 of the fertilization, this trophoblast divides into villous trophoblast and extravillous trophoblast. The villous trophoblast forms syncytial trophoblast, which is the outer multinucleated syncytium, and the cytotrophoblast, which is the inner mononuclear cuboidal cell layer. This is a single cell layer with a nucleus. So we should know that the cytotrophoblast, which is a single cell layer with nucleus, it has a well-demarcated cell border, and it has ability to undergo DNA synthesis and mitosis. This is very important. So these are the syncytial trophoblast and cytotrophoblast are the parts of the villous trophoblast, that is villi, primary, secondary, and tertiary villi. The second part of the trophoblast is extravillous trophoblast, which again consists of two parts, interstitial trophoblast and endotrophoblast. And this covers the maternal vessels. Now I show you this picture. So this is the villous part of the trophoblast, which has primary villi, and as the growth increases, by day 17, they become tertiary villi and vascularized. It has got an outer syncytial trophoblast, and the inner one cell layer is the cytotrophoblast. The second trophoblast is extravillous trophoblast, these cells which you can see here. This is the decidua bassalis of the where the placenta is attached on the uterine wall, and this is the myometrium. In the decidua bassalis and the myometrium, the spiral coiled arteries are running. So the interstitial trophoblast is surrounding the spiral arteries, whereas endovascular trophoblast, which you see along with the spiral arteries, this invades the spiral arteries. First, at day 12, it invades the spiral arteries in decidua bassalis. By day 16, it invades the spiral arteries in the myometrium. So when the endovascular trophoblast, it invades the spiral artery, these become the low resistant blood flow vessel, which was coiled and high resistance vessel. When the women, this is in the pregnancy, they become the barrels of low resistance. There is blood flow, they dilated, and they are the barrels of blood flow with low resistance. But when we can just go on to that first, but when she has preeclampsia or fetal growth restriction or preterm birth, this invasion of the endotrophoblast into the spiral arteries is absent. These endotrophoblast does not invade the spiral arteries in preeclampsia, in fetal growth restriction, and preterm birth. So there lies the importance before 16 weeks, starting of ecosprin. So this can be predicted on the blood flow or the color Doppler. So day 9, the blastocyst faces the uterine lumen. Day 10, blastocyst is encased in the endometrium. And day 12, there is intercommunicating channels between the maternal blood and the villi. On the fetal side, it is the villi, primary villi becoming tertiary villi by day 17 and becoming vascularized. And they become in communication with the maternal blood, which is flowing in the lacunae. So these are some changes which we can see on day 10 and day 12. Now this is the day 17 picture of the placenta. Now this is the umbilical cord. This is the fetal side of the placenta. This is the fetal side. First is amnion. Then this one is the chorion. And these are the villi. They were earlier primary villus. By day 17, they become secondary and tertiary villus. And the red is the chorionic artery. Each chorionic artery is supplying the tertiary villus, making this tertiary villus separated by the septa, a cotyledon or a single functional unit. So it is very essential that the angiogenesis, it occurs by day 17. This blood vessel you can see, it's going into all villi. And this is the maternal side, myometrium, decidua basalis, and maternal blood vessels, arteries and veins. So in between the intervillous space is the maternal blood, which is in contact with the tertiary villi. So it is a hemochorial placenta. So what is the clinical significance? I've told you that if the invasion of the endovascular trophoblast into spiral arteries is defective, here you see, then it leads to preeclampsia and fetal growth restriction. Now, these are the tertiary villi, and they invade the decidua basalis, and then they invade the myometrium. And normally in the placenta, beneath the decidua basalis, there is a layer of fibrinoid degeneration, which is called Nita-Book layer. But as and when, sometimes there is defective decidua. This is the normal. These are the tertiary villi. This is the decidua basalis. This is the myometrium. So this is the normal stage. And this one is the Nita-Book layer. But sometimes what happens, like you see in this picture, the decidua is defective, where the tertiary villi, they are invading the decidua basalis. The decidua basalis is defective, and there is absence of Nita-Book layer. And this is where the placenta accreta syndrome occurs. So absence of Nita-Book layer in the placenta predicts to do a histopathology that this woman is going to have a placenta accreta syndrome. So normal placenta is round to oval, 22 centimeter in diameter with a thickness of 2.5 centimeter, varying between 2 to 4 centimeter as a placental disc, and amnion and chorion as membranes. The umbilical cord is 3 vessel. Maternal surface is basal plate, called basal plate, and it is divided into 15 into 38 cotyledons. And the number of cotyledons which are formed, they remain the same throughout the pregnancy. It is only that they increase in the size as the pregnancy grows. While fetal surface has chorionic plate and a centrally attached umbilical cord with large fetal vessels passing through the tertiary villi, the angiogenesis, which occurs by day 17. And whenever the angiogenesis does not occur in the tertiary villi, or there is lack of vascularization of the tertiary villi, the condition becomes hydatiform mole. So if what is at mole, there is no vascularization of the tertiary villi. So what we have talked, this is the fetal side of the placenta, and this is the chorionic plate. This is maternal side of the placenta. These are the cotyledons, and it is convex. And these are the fused amnion and chorion membranes covering the placenta and cord. So this is again the same picture, uterus, the corneal attachment of the placenta. Here, decidua basalis, and this is decidua vera, chorion, amnion, which forms the membranes. So how does the placenta grow and maturates? In the first trimester, the growth of the placenta is more than growth of the fetus. By 16 weeks, there is continuity of the cytotrophoblast is lost, and syncytium vessels, they become prominent. By 17 weeks, the weight of the placenta and fetus, they equal each other. And at term, the placenta is 1/6 by weight of the fetal weight. Maternal surface, always convex, cotyledons 10 to 38, and the lobes or cotyledons are separated by grooves. The lobes remain throughout same, and each cotyledon with a tertiary villus, which is vascularized, is called functional unit of placenta. So placental lobule or cotyledon is the functional unit of placental architecture, and each cotyledon has a single chorionic artery and a single chorionic vein. So inside the tertiary villus, now these are the villi. Inside the tertiary villus, the villi also has villus stroma, and this stroma is dense and it is closely packed with spindle-shaped cells. And there is also, the stroma is also infiltrated by Hofbauer cells, and these Hofbauer cells, they act as macrophages. They are round and vesicular with the eccentric nuclei. These are the Hofbauer cells, and they are mediators of protection, and they produce cytokines. They provide paracrine regulation of the trophoblastic function. Placental circulation consists of two systems, uteroplacental circulation and the fetoplacental circulation. And at term, the uteroplacental blood flow ranges between 700 to 900. So a word about this is our placenta. This is the fetal side, umbilical cord, mother side. So the deoxygenated blood, it has two umbilical arteries and one umbilical vein. The deoxygenated blood from the fetus, it comes through the umbilical artery and it starts flowing in the intervillus space. Ye dekho na? This is the tertiary villi and this is the intervillus space. So maternal blood is flowing here. Deoxygenated blood from umbilical arteries flows here. Exchange of gases, nutrition take place here. And with the vessels, chorionic vessels in the tertiary villi. And then the oxygenated blood, it goes back by a single umbilical vein and it supplies to the fetus. The factors which regulate the intervillus space blood on the maternal side are arterial blood pressure, intrauterine pressure, uterine contraction pattern, and the factors that act on the arterial wall. So whenever there is high blood pressure, there is vasoconstriction, there is no invasion of the spiral artery by the endotrophoblasts. So that can lead to decreased flow in that space, intervillus space. We should all know that the spiral arteries, they are perpendicular, while veins, they are parallel to the uterine veins. So spiral arteries are perpendicular to the uterine wall and spiral veins, they are parallel to the uterine wall. And this carries a significance that whenever there is uterine contraction, the spiral veins, there occurs closure of the veins. And it prevents the maternal blood to go away to the back. So maternal blood remains in the intervillus space during the contraction. This is a defensive mechanism. Then fetoplacental circulation, we have just talked, deoxygenated blood through the umbilical arteries goes into the intervillus space. There is exchange of blood with the tertiary villi, and by umbilical vein, it goes back into the chorionic, to the fetus through the chorionic arteries. There is another important thing that before 10 weeks of pregnancy, the end diastolic flow cannot be detected, while after 10 weeks, the end diastolic flow in the umbilical arteries appears and it is maintained throughout the pregnancy. Now, it's not that there is an absolute integrity in the placenta. The cells traffic between the mother and the fetus in both the directions. So we can say that there are some breaks in the placental barrier, and these are responsible for certain clinical conditions during pregnancy. So if the mother is Rh negative, and they can be erythrocyte D and baby inside is Rh positive. So there can be a erythrocyte D antigen alloimmunization even in a primary gravida. So this we should always take in mind and always do an indirect test. And second is some of the fetal cells, they transfer into the maternal circulation, into the maternal bone marrow, and in the maternal reticuloendothelial system. They remain dormant there for a long time, and they may wake up late in life, and this is called microchimerism. And how does it manifest? That the mother later on can have autoimmune disorders like lymphocytic thyroiditis, scleroderma, or SL because of this disease. And a very important event of this millennium is that we should know, because of these breaks in the placental barrier, that 10% of the cells in the maternal blood are cells from the fetal trophoblast. 10% of the blood cells in the maternal blood are fetal trophoblast cells. So this is at 10 weeks. So this is one of the cell-free fetal DNA after 10 weeks of pregnancy is one of the screening tests for the non-invasive screening tests for the aneuploidies. As we talk a little about the hormones which the placenta produces, of the most importance are human chorionic gonadotrophin, progesterones, and estrogens. So we'll talk a little about them. Now, serum beta HCG becomes detectable by day 7 to 9 after the mid-cycle LH surge or 2 days after post-fertilization. This peaks at 9 weeks. The highest levels of HCG are at 9 weeks of pregnancy. Then it becomes plateau and remains same throughout the pregnancy. The serum beta HCG may be raised if she is a case of Down syndrome, which forms a dual marker for aneuploidy screen. They may be raised in gestational trophoblastic disease, erythroblastosis fetalis, or in the trophoblastic neoplasias. Then the serum beta HCGs, they are reduced whenever there is a failing pregnancy in form of any type of abortions or in ectopic pregnancy. Then there are certain fetal conditions which affect or decrease the estrogen production by the placenta. And the most important is the anencephalic fetus. Since the hypothalamic pituitary axis is absent in the anencephalic fetus and the adrenal glands are atrophic, so absent adrenal fetal zone leads to very constricted and restricted estrogens. They are severely limited. Then in a condition, fetal adrenal cortical hypoplasia. Also, there is absent C19 precursor of the estrogen leading to very low estrogen. Then these are the other conditions: fetal placental sulfatase deficiency, aromatase deficiency, where again estrogens, their production is decreased. And trisomy 21 Down syndrome also have low serum unconjugated estradiol levels, which is one of the markers of quadruple screening. Then in fetal erythroblastosis also, there is elevated maternal plasma estrogens because of the greater placental mass and fetal hemolytic anemia. Then in H-mole and gestational trophoblastic neoplasias also, they lack C19 steroid precursors, and hence there is reduced estrogen biosynthesis. Maternal conditions which lead to decreased estrogen production, that is if a mother is on glucocorticoid treatment, or she's a patient of Addison's disease, or she has an androgen producing tumor, there'll be low levels of estrogens. Now, placenta is an organ of transfer between the mother and the fetus. The syncytial trophoblast, multinucleated syncytial trophoblast, facilitates substance transfer. The transfer of nutrition, gases, electrolytes can be by four ways. It can be by bulk flow solvent drag, that is from higher osmotic pressure to lower osmotic pressure, water and dissolved electrolytes. They pass like this from the mother to the fetus. It can be a simple diffusion, and oxygen, carbon dioxide, and anesthetic gases, they pass by simple diffusion. Then nutrients and other substances, they exchange by simple diffusion. However, insulin and steroid hormones and thyroid hormones, they pass by simple diffusion very slowly through the placenta. Then another process of exchange of between the fetus and the mother is exocytosis and endocytosis. We should know that the high molecular weight antibodies, they do not traverse placenta. So fetus, except for IgG, then fetus, it depends on placenta for its pulmonary function, hepatic function, and chorionic villi and intervillous space. They function together for as gastrointestinal tract and kidneys. The oxygen supply rate to the fetus is 8 ml of oxygen per minute per kg body weight of the fetus. Placenta, we should remember, is highly permeable to carbon dioxide, and carbon dioxide traverses by diffusion faster than oxygen. So these are the various variables for maternal and fetal substance transfer. And I think we can go further. Now, something very important, every day we obstetricians are doing deliveries and cesarean section. Baby cries given to the mother, we are so happy. But we are incomplete in our work if we do not examine the placenta. She may come later with a PPH. She may have a sexcentriate lobe. She may have a velamentous insertion. So it's very important to examine the placenta. So all placentas should be examined grossly in the delivery room, and it is mandatory. Umbilical cord should be examined, number of vessels, length of the cord, and any insertion, whether it is central or eccentric or marginal, and for any abnormalities, there could be false knots, there could be true knots. Then parenchyma, that is placental disc, should be examined for any discoloration. It may be green, it may be because of meconium, then it may be yellow because of infection. Then membranes also must be examined for the color, placental insertion, and membranes. Now, there are routine pathological examination is not indicated of placenta, but these are the indications: death, neonatal resuscitation, preterm or postterm birth, multiple gestation, obstetrical complications, hydrops, severe neonatal anemia, neonatal sepsis, FGR, and small or large for dead babies, or abnormal placenta or maternal disorders. So here we may have a pathological examination of placenta. How we should handle the placenta? We should know that the information regarding gestational age and pregnancy be provided on the pathology requisition sheet. Clinician must document in their notes, delivery notes, any gross abnormality, length of the umbilical cord, any true knot. And if there is multiple pregnancy, it should be always labeled. Pair each infant with its umbilical cord and with the clamp. One clamp for the firstborn and two for the secondborn. And safest procedure is that we should send the placenta to the pathology department. Yes, they can keep it for a few days in their fridge. And if then we don't need, they may not do anything and discard it. And if needed, they can freeze it later if we order it. So placenta with its indication should be refrigerated, and it can be fresh placenta refrigerated, can be stored for several days. Now, whether the information regarding various placental abnormalities is better in fresh placenta or fixed placenta is a very important question for all of us. The fresh placenta is preferable as it appreciates the placental surface, membranes, and solid lesions better. The fixation of the placenta, it alters the placenta weight, placental color, but it improves the identification of parenchymal lesions. Now, if we need any cultures and genetic studies on the placenta or bacterial cultures, it should always be done on the fresh tissue. For viral cultures, they should be on the fresh placenta. And if we need to do for the B streptococcus also, which is lethal for the fetus in PPROM. So this should all be cultures, and genetic studies should be on the fresh culture. For genetic studies, umbilical cord remains the best source as it is it has minimal maternal contamination, and otherwise we can take the chorionic plate. The parenchyma, that is maternal tissues, villi, and circulating fetal blood, they all, if needed, can be fixed. Now, whenever we must weigh the placenta, and the average weight is 470 grams, if we have a heavy placental weight, then it means she can be a diabetic, she can have a fetal or maternal anemia, fetal hydrops fetalis, placental mesenchymal dysplasia, or congenital syphilis. And if the placenta is less than the normal weight, it could be preeclampsia, fetal growth restriction, aneuploidies or fetal malformation, fetal alcohol syndrome, or infections, viral infections. So maternal surface is red, maroon, spongy, and we should take cut strips from the maternal surface 1 to 2 centimeter along the chorionic plate. If the color of the maternal surface is mottled or it has firm areas, it is abnormal. Firm areas signify chronic villitis and fetal vascular malperfusion. They can be infarcts, intervillous thrombi, cysts, abscesses. If the placenta is disrupted at some placenta, think of placenta equita syndrome. And if there are blood clots on the placenta on the maternal side, it signifies a rupture placentae. Then there can be an intervillous thrombus, can be seen in the placenta, and we should measure it. Then fetal surface is usually shiny gray, blue, purple, or translucent, and we can see chorionic vessels on the fetal surface. Always inspect large vessels, which suggest a subcenturate lobe, or which may be torn or may be left behind. So various types of placenta can be a bilobed placenta. So if there is any malformation or in any variant of placenta, we should always take a picture and mark it. And cord may be inserted in between the two lobes. Then there can be a multi-lobe placenta, or there can be a placental subcenturate lobe. So the clinical significance is where if the extra lobe is low-lying, it can lead to antepartum hemorrhage. And if the extra lobe, subcenturate lobe is retained, patient may come back with postpartum hemorrhage. So how important it is to examine the placenta. Now this is the picture. This is the normal placenta, which is situated posteriorly and in the upper segment. This is the vessels, and this is the extra lobe or subcenturate lobe in the lower segment. And this is the picture of this patient. And the two lobes, they are connected by the artery and the vein. So one lobe is, the extra lobe is in the lower segment. Then placenta can be thin and membranous. Again, they are larger, placenta membranacea, and they can be a cause of placenta previa or placenta accreta. Then ring-shaped placenta can be there, which can lead to antepartum and postpartum hemorrhage and fetal growth restriction. There can be a central hole in the placenta fenestrate, and these are the types. Then there can be large placenta, which can be thicker. We have seen that these are the causes: diabetes, anemia, hydrops, anemia, torch infection, cytomegalovirus virus infection. Then this is the picture showing placental mesenchymal dysplasia, where there are large cystic vesicles with enlarged stem villi. But this is a very rare condition. Then circumvallate placenta and circummarginate placenta. Now circumvallate placenta is when there is a thick fibrin and old hemorrhage. Placental disc is smaller and it is surrounded by a thick fibrin and old hemorrhage between the placental disc, and this is amnion corona, and this is the disc. And this is circummarginate placenta, and this is circumvallate placenta. This is circumvallate placenta, and here on ultrasound also we can diagnose this circumvallate placenta. You can see this thick band of fibrin and hemorrhage deposition. Then there can be infarcts in the placenta. Peripheral infarcts are common. Small infarcts are without any significance. But if there are large infarcts or if they are bigger, then they can lead to FGR, and they signify that uteroplacental insufficiency. Then large or central infarcts, they can also lead to neurological sequelae, stillbirth, fetal growth restriction. Then placenta may sometimes be hydrops. You see, like in HMOL, this is idiomatous placenta, hydrops placenta, which can be seen in RH incompatibility, severe fetal anemia, and in intervillous thrombus. Then this is very important. When we were students, we always used to ask ultrasonologists to grade the placenta. And now it has, I don't know, we send them, but they by themselves never grade the placenta. So it is the placental calcification increases with grading of the placenta. Grade 1 is as the gestation increases, calcification increases, so is the grading increases. So grade 0, no calcification. Grade 1, scattered echogenicity. Grade 3, echogenic stipplings in the basal plate or comma-shaped stipplings. Grade 3 is echogenic indentations from chorionic basal plate, and it increases in density, creates cotyledon component. Now, this is if the patient is less than 32 weeks of pregnancy and there is increased calcification, which means that it is grade 3 placenta. This signifies adverse pregnancy outcome and maybe even stillbirth. So we should always be, if a woman is 30 weeks and there is the placenta is grade 3 with hypercalcification, then we should always keep a strong vigil and find out the cause. She could be case of severe preeclampsia, fetal growth restriction, and the Doppler studies will also show. So if there is grade 3 placental changes before 32 weeks, it is a marker of adverse pregnancy outcome, and even stillbirth can happen in these patients. As regards placental tumor, the one tumor is chorioangioma. Choriofangiomas of placenta less than, the incidence is 1%. If they are in the size less than 4 centimeter, they are not of much significance. But if they are more than 4 centimeter, they can lead to hydrops vitalis, high output cardiac failure in the baby, and fetal death also. Then metastatic tumors in placenta are very rare, but still, whenever a patient has melanoma, leukemia, lymphoma, or breast cancer, we can think of metastasis in placenta also. Then umbilical cord, we'll hurriedly do it. That general appearance is smooth, white, opaque, shiny, and the coiling index is 0.2. That is, there should be 2 coils in 10 centimeter length of the cord. The normal range of the length is 35 to 77 centimeters. We should always mention the length of the cord. Short cord, less than 30 centimeters, indicates inactive fetus, fetal malformations, myopathies, neuropathic disease, and oligohydramnios. Long cord, more than 70 centimeters, indicates hyperactive fetus. There can be, in such cases, cord entanglement, cord prolapse, knotting, intrauterine hypoxia, and fetal growth restriction. So the coils, they reflect the fetal health. So there should be at least 2 coils per 10 centimeters. If it is an uncoiled umbilical cord, that also signifies adverse fetal outcome. Congenital anomalies, fetal heart rate anomalies, FGR, preterm birth, and intrauterine death. If it is hypercoiled, that is also, in that also, it can be a FGR baby, small for the gestational age, and non-reassuring fetal heart rates. Both are bad. Then there can be false knots, not of any significance. True knots can be seen in hydroamnios and diabetes mellitus. And if there is a tight or multiple true knots, intrauterine death can occur. Or if there is a hanging noose, the stillbirth rate is 4 to 10-fold more in a true knot. Then single umbilical artery, we should always see for. We should cut the cord 5 centimeters away from the placenta. We should cut and see that there are 2 arteries and 1 umbilical vein. If there is a single umbilical artery, and this is on our all aneuploidy screen ultrasounds, we always see for the single umbilical artery. The single umbilical artery in low risk may not have fetal aneuploidy, but may lead to fetal growth restriction. But whenever we see a single umbilical artery on targeted scan or first trimester anti-NP scan, we should always go for a targeted sonography, fetal echography, and if need be, we may do amniocentesis and karyotyping also, because if there are associated cardiovascular and urinary tract anomalies. Otherwise, single umbilical artery isolated may not have any aneuploidy. Then the insertions may be battle door, that is by the end of the
We are running short
so we
of
can
time.
go further.
Yeah.
So these are
Yes,
some
ma'am.
pictures, bifurcate placenta, cord showing inflammation. And this is very important, that if the cord is red, brownish and red, it is in the fetal death, cord will always be red, dark brown. So we can go further, I think. So the take home is that visual placental examination by obstetrician is recommended in delivery room. Placental examination is essential part of autopsy in cases of fetal or neonatal death. Pathological examination not to be done in routine, only when there is a specific indication. Thank you.
My God, what such a elaborate talk, madam. You gave us
Absolutely.
fantastic. It was a complete webinar atlas of placenta was revealed to all of us. Thank you so much for your elaborate talk. Dr. Chug, your comments, please. Unmute, madam. Unmute.
Okay. It was a good review and very elaborate talk, Dr. Ruby. And I think a very good take-home messages also. I don't know actually how many gynecologists examine placenta. And after going through your, this talk, we can just, understand how important it is to see the color, size, cotyledons, color of the cord, knots, everything. So many things, 1, 2, 3, 4, 50 things I think we have to see. I don't know practically how many of us are doing. I'm still afraid of it. So thanks a lot for your elaborate talk, and I think you left nothing to be asked by the audience. So thank you very much for everything.
Thank you.
Thank
you
you,
for
ma'am.
making me a part.
When we asked ma'am, when I asked her, you have to talk about placenta, she said, placenta ke bare mein kya?
Exactly.
And what not you have told us about placenta. Thank you, ma'am.
Madam is teacher of teachers.
Yes, that is what a teacher is all about.
Thank you
we are
so
lucky
much.
to have Dr. Ruby in our Her of Guide. And now we'll have
Thank you.
another grand talk by our next speaker. Before that, I would now invite, since Dr. Vibha could not join us, now Dr. Vibha is here.
Ma'am, I will leave for some time and rejoin in panel as I am not well. I'll take some medication.
And
Sure,
so
sure.
ma'am was down with fever and she's taken crocin. And then she has come and given this talk. So,
Oh my God.
hats off to you, ma'am.
So nice.
So nice.
So nice.
Dr. Vibha,
we are obliged.
Yeah, we have a guests of honor, Dr. Vibha and Dr. Vanna Punya. Both have joined now. So I would invite Dr. Vanna Punya, who is the ex-president of Women's Doctor Wing Haryana, who's also ex-president of Mission Pink Health Haryana, and also ex-president Bhiwani OBGYN Society. So, Dr. Vanna, we would like, we were missing your presence during the inaugural, and we would take your comments now.
Thank you, Dr. Jyoti. Thank you,
Yes.
Dr. Jyoti, for making me part of this wonderful webinar. I would not like to take too much of time because we have such wonderful speakers and such wonderful topics to hear and so much to gain from their knowledge. And I was listening to Dr. Ruby, and like what you said, what not she told us about placenta. It took me right my anatomy days and carried on to the all my years of MBBS, and still so much to learn. So I think thank you so much for making me part of it. And I will not take time. I know you're all running short of time. And such wonderful webinars being organized by these organizers. Thank you, Dr. Ragini, Dr. Jyoti, Dr. Varsha, and it's an honor to be sharing a platform with such wonderful stalwarts in
Thank you,
our field.
madam.
Thank you so much. Thank you so
Thank you,
much.
Dr. Vandana Punia ji, for gracing the occasion, and
Thank you,
have
Dr.
made
Varsha.
us
Thank you
very-
for making me a part of it. Thank you. And I'm eager to
Thank you.
listen to the coming speakers now.
Yeah.
Yes, yes.
Thank you, Dr.
I would
Vandana.
now invite Dr. Vibha Dua, who is the Senior Vice President of Haryana OBGYN Society, so organization. So I would like you to give some pearls of wisdom. Dr. Vibha Dua, who is a Senior Obstetrician Gynecologist, life member of so many organizations, Senior Vice President of Haryana OBGYN and Senior Consultant of Dua Hospital of Haryana, Sonipat. Madam, please. Vibha Dua.
Ji, good afternoon, everyone. Good evening, sorry. And I could not join because of some technical error, although I was present since 3:45 p.m. I will request now to continue the session. It's so good going on. I hope it will be very informative and interesting for delegates also. So I think session should go on. And I am impressed by Dr. Varsha also, who I am meeting for the first time in this webinar. Rest all I
Thank
know.
you so much, ma'am.
Thank you so much.
You all
Thank
have
you.
so lovely aura. I'm really thrilled to watch you all. Thank you so much for gracing the occasion.
Thank you.
Thank
So
you.
moving
Please
on,
continue.
we come on to the second topic, which is placenta in APH. So we would be talking about placenta previa and also the abruptio. So it is going to be another, I think, marathon, but I think Dr. Richa will be fast enough to cover, to take us through that. And for that, I would invite my chairpersons. If we have Dr. Poonam Lomba, ma'am, we have Dr. Poonam Lomba, who's president of the Ambala OBGYN Society. And she was the founder chairperson of the Haryana chapter of ISAR. And she was also the honorary librarian of ISAR in 2019-2020 and director of Lumba Hospital IVF Ambala with many affiliations, awards, and achievements to her credit. If Dr. Poonam Lumba is there, ma'am, please unmute yourself and maybe you can switch on your video because I'm not able to spot you. We have our second chairperson is Dr. Aarti Kaushal. Dr. Aarti is the president of Karnal OBGYN Society. She is consultant Life Care Hospital Karnal, and she did her MD from Ahmedabad, and then she has come down to start her practice in Karnal. Now, presently, she is president of the Karnal Association of Obs and Gynae and member FOGSI, IFS, Mission Pink Health, treasurer IMA Karnal, and with a special interest in high-risk obstetrics. So over to Dr. Aarti to introduce our speaker, Dr. Richa Kansal.
Hello, Dr. Jyoti, can you hear me?
Yes.
Okay, thank you so much for making me a part of this webinar. And it feels so great to interact with the stalwarts through this webinar. I would extend my greetings and regards to the chief guest, our guests of honor, the distinguished speakers. And now for the topic, we all know the second topic for today's webinar is placenta in APH. All obstetricians know that APH still remains a major cause of perinatal mortality and maternal morbidity. And as obstetricians, at all times, we must stay updated in skill as well as knowledge to deal with such cases. So we have with us Dr. Richa Kansal, who is a distinguished speaker. She'll deliver a talk on placenta in APH. She's a very learned person, and I'm sure it's going to be an academic feast.
Thank you for the kind words, Dr. With the permission of the chair, may I please share my screen?
welcome Dr. Aarti Kansal, Dr. Richa. Thank you for coming over here and giving your inputs and elevating the standard of this webinar, which is very, very important for us as an obstetrician placenta. Such an important subject to discuss.
Thank you so much. Thank you. I'll begin with saying a very good afternoon to all of you. Probably evening to all my seniors and your colleagues. And thank you, organizers, especially Dr. Jyoti, for giving me this opportunity. I've been given the topic placenta in APH to talk about today, and I think like it's a vast topic, and I like to do justice to it. And the way that I have approached this topic is two-pronged. That we have placenta and APH as two separate conditions, and we really covered this topic nicely. Dr. Ruby did justice to it. While we talked about placenta per se, the wonder organ, I should call it, that is there in pregnancy. So as we talk about placenta further, the normal placenta is a boom, but at the same time, whenever the variations happen, they can alter, and there can be conditions, something that is called as APH. So with that, we are going to begin, and the APH or antepartum hemorrhage, the big risk that we are having is, I think I am able to, is my screen visible?
Yes.
Okay, so hemorrhage in pregnancy still remains an enigma, and we have, as my learned chairperson pointed out, a major cause of maternal death as well as near miss, and is affecting both maternal and fetal conditions. Now let's talk about, once we are going to talk about this hemorrhage, the hemorrhage can occur early in the pregnancy. That forms one entity. The other one that is considered as APH or antepartum hemorrhage, and the other entity that comes in, or the last entity comes in, as postpartum hemorrhage. So today we are going to talk about antepartum hemorrhage. As per definition, antepartum hemorrhage is a bleeding into or from the genital tract from 24 plus 0 weeks gestation and prior to the birth of the baby. Complicates roughly 3 to 5% of pregnancies, and is a leading cause of mortality as well as morbidity worldwide. We understand that preterm deliveries have also been strongly associated with APH, but at the same time, we need to understand that this preterm delivery is occurring because a complication of APH has happened. The important causes that are counted up for APH include placenta previa and placental abruption. These are the abnormalities of the placenta that we are going to consider on. They contribute only to the 50% of the cases, and the remaining are actually caused by the other causes as well. So though not most common, but are most important, because the morbidity and mortality affection is much high whenever these particular conditions are associated. Now, a special mention is definitely warranted by vasa previa, because vasa previa is another placental cause in which the hemorrhage is not occurring actually of the mother, but of the fetus, and we will discuss it as we go along the course. The other causes, you're very well aware of APH, can be cervical polyp, vaginitis, cervicitis, varicosities, to count up among some. So let's find out the prediction and prevention of PPH. Can this be prevented or predicted? So we need to understand that there is a heterogeneous pathophysiology, and as such, the steps to prevention will probably include identifying the risk factors for these individual conditions and preventing them. If we take for an example, like a previous cesarean, that is, or a DNC that is happening, that is predisposing a patient to subsequent placental abnormalities, and hence APH can actually be avoided. So good contraception or good care of the patient is something that can only provide prevention. Otherwise, there's nothing much that is there that can be done on, and we'll be discussing it further with the individual causes that are there. Women should be advised, encouraged, and helped to change modifiable changes. Some of them might actually help. Of importance here is that all women should be advised to report all vaginal bleeding to their antenatal care provider. Now, this is a single and foremost point to pick these patients up at an early stage and probably manage them in such a way that the problem does not happen. Blood transfusion services, operation theater services, laboratory, neonatal anesthesia, resuscitation services for the neonate. All these are required with a good obstetric unit, and a multidisciplinary team should be there wherever the management of APH is actually planned. If you think about the course of the pregnancy in these APH cases, the complications definitely happen and are more likely to occur whenever the hemorrhage is due to a placental cause, when the bleeding is heavy, or when the bleeding occurs at an early gestation. So blood loss and APH, if we talk about, then there are no consistent definitions wherein the severity of the APH can be defined up. It can be recognized by the amount of blood loss, but we need to keep in mind that at times the blood loss might not be representative of represented in the total bleeding that is seen or apparent with the patient. And the most common example is a concealed placental abruption. So it is important that while estimating the clinical features or the hemodynamic status of the patient should always be taken into account, because volume depletion is one important aspect that one can be affecting the fetal condition as well as mothers in a important way. So let's take up some definitions as to how we acknowledge how much is the amount of bleeding with APH, because the management is going to be dependent on that. If you talk about spotting, it can be staining, streaking, or blood spotting noted on an underwear or sanitary protection. Minor hemorrhage, less than 50 ml. Major, it is 50 to 100 ml with no signs of clinical shock. And massive hemorrhage you call whenever there is a blood loss that is more than 1,000 and or signs of clinical shock. Now, where the importance here is that even if the blood loss is less than 1,000, but the signs of clinical shock are evident, the case has to be treated as a case of a massive hemorrhage. The another term that we are going to use is recurrent APH, and this term is used whenever there are episodes of APH more than once. So placenta previa. Placenta previa is the first cause that we are going to take up in this discussion today. I'm going to skip out the certain information that we all are aware of or shorten out those things so that I can meet up my presentation in time. So placenta previa, when the placenta lies in the lower segment, we all understand lower segment, the part of the uterus that is formed by the isthmus lying in between the anatomical internal os and the histological internal os. Now here, the reaction that is occurring, the desiccal reaction that is occurring is somewhere in between the uterine and the cervical. And hence the descentralization is not that good, one. Second thing, the vascularity is not that high that it can meet up. The changes that are there from the basal part of the mother is not going to be good enough. So the placenta that is implanting in the lower segment is defective by the means of its location, that it is not actually implanting into the body proper as we understood with the normal placenta, but is implanting in the lower uterine segment that is somewhere in the junction between the uterus and the cervix. The second point of importance here to consider is that the placentation that is going to happen in these cases might be defective, and in these such situations we might encounter certain special conditions like placenta accreta. I'm not going to talk about placenta accreta because there's a whole panel on it, and I know for sure that they are going to cover it up nicely, so I am avoiding that coverage here. Then placenta accreta is one problem that can happen along with previa. Other things that can happen is that whenever the separation happens, the slight separation or the migration of the placenta that is happening can result up a low-lying moving upwards, but will also result up in a placenta which is low-lying, but causes shearing at the margin, and hence the sinuses of the placenta bleeding over the time, resulting in recurrent vaginal bleeding. Now, this recurrent vaginal bleeding may again present as APH, and as we very well understood, the placenta previa, the bleeding whenever it is going to happen can be variable. At times it might be spotting, or at times it might be so heavy as to warrant a massive hemorrhage and definitely an emergency management. So let's see the classical grading of placenta previa. We have type 1, 2, 3, and 4. 1 that encroaches but does not reaches to the internal os. 2, we grade when it reaches the internal os but does not cover it. 3, when it partially covers it, that means when the os is fully dilated, it will not be completely covering the os. And fourth, when it completely covers the internal loss, even with a dilated stage. We understand we can divide into anterior and posterior. We understand that we are having minor and major placenta previas, and this is basically the clinical division that has happened. The minor includes type 1 and type 2 anterior, type 2 posterior, 3 and 4 are all included in major placenta previa, in which a heavy bleeding is encountered whenever we have these cases, and they'll end up in labor or contraction start or otherwise as well. Now, another importance to understand is the risk factors that are associated with placenta previa. I'd like to call your attention to previous placenta previas whenever they have happened in previous pregnancies. Please pay attention that the odds ratio is to as high as 9.7, and it constitutes a very major risk. If we talk about placenta previa in previous cesarean sections, see the previous one cesarean section, the incidence is 2.2 as odds ratio. 2 cesarean section brings it to 4.1, and 3 brings it to 22.4. So that calls for an important point to understand here. A prevention will mean that we reduce the incidence of cesareans that are happening in our practice. Previous termination of pregnancy is again a risk factor. The others include multiparity, advanced maternal age, more than 40, multiple pregnancy, smoking has been associated, deficient endometrium due to presence of or history of uterine scar, endometritis, manual removal of placenta, curettage, some mucous fibroid, all contribute to placenta previa. Assisted conception is another indication, another condition that is associated with a higher incidence of placenta previa. So, as we talk about prevention, we understand the only thing that can happen is that we can reduce the causes that are resulting in placenta previa. So, reduction in the cesarean rate, reduction in DNCs or failed pregnancies. So, those are the only ways with which the probably the prevention of placenta previa can happen. Now let's talk about the prevention of APH if the previa has happened, and what precautions can be taken in order to reduce bleeding in this placental cause for APH. So the recommendations, as we see, we have to avoid any vaginal or rectal examination in the patients with placenta previa, and need to advise these women to avoid penetrative sexual intercourse, because in all these conditions, it is possible that the patient might start bleeding. Now, there is no place for the use of prophylactic tocolytics in women with placenta previa to prevent bleeding. In cases of placenta previa, the another question that was raised was if we can arrest the further movement of the lower uterine segment, and hence cervical encerclage can either be used in order to reduce the amount of bleeding or episodes. But it was found that in literature, as well as supported by the studies, that there is no sufficient evidence to recommend this. So it has not been tried, because we understand the placenta that is lower may actually start bleeding if it is not, the cerclage is taken up adequately. So this practice is not recommended. So as we understand, no vaginal or rectal examination, that is without indication. The other thing is avoid sexual or cohabitation or sexual experience, that is a penetrative sex. The evidence regarding prophylactic tocolytics and that of encerclage, there's no clear-cut indication that any of them works. So don't. So let's come back to the clinical features. We understand that traditionally that we have taken up that the bleeding is going to be causeless, recurrent, and painless. This is going to be a bright red bleeding. We understand the uterus corresponds to the period of gestation. We understand that there is no tenderness. Usually contractions are not there, but light contractions may also be present. Vaginal bleeding might be there. With this vaginal bleeding, whenever she is presenting with, is having a tendency of being bright red in color or a fresh bleeding. Lion presentation may be abnormal because the placenta is occupying the lower pole of the uterus. And low-lying placenta on a 20-week anomaly scan actually gives you an indication that probably you are having a placenta previa. That you need to confirm via scan again. And as we understand that ultrasound is one of the good investigations that can pick up for this. So we include the triage of a patient who has come to us as APH and antepartum hemorrhage with placenta previa. We understand that we have to segregate the patient into a patient who is hemodynamically stable or unstable. We have to understand that we have to categorize them as per how exactly to manage further. So history taking, you have to identify whether there is a coexisting symptom like pain, assess as per the amount of bleeding that has happened, the hemodynamic status of the patient, as well as the cardiovascular condition of the mother, because that will have a bearing over the management part. Assessment of the fetal well-being. Now, this another is going to dictate what management I am planning for my patient. So major or massive hemorrhage, if you identify or you are able to find out that one, then please do not waste your time. Resuscitate the patient immediately. The mother is a priority and should be stabilized prior to establishing the fetal condition. That means do not even wait for looking for the fetal heart. First stabilize the patient and then move ahead for anything else. So investigations, when we have put in wild board cannulas in these patients, it is preferable
Sorry,
to... Yes, ma'am.
excuse me. Sorry to interrupt, Dr. Richa. I think you'll have to finish your talk in next 5 minutes or so. I hope.
Okay, we'll
Thank
do
you.
that, ma'am. Thank you. Okay, so the investigation part, we need to go for the vital signs, the pulse rate, the BP, the respiratory rate, the oxygen saturations, temperature of the patient. Investigations, a full blood count, including the blood group type or cross-matching, Kelly-Hauser if she's Rh negative, clotting profile, as well as LFTs and RFTs and electrolytes are good. Even ABG or blood gas analysis is going to be helpful in these patients who are bleeding. So the investigations can include ultrasound and cardiotocography, because ultrasound is going to confirm my diagnosis and cardiotocography is going to let me know regarding the patient condition. So the differential diagnoses we are already aware of. As for the management, we understand that if a patient is not bleeding, then we need to watch her up and take her up in case wherever we are having a major degree of placenta previa, as a cesarean section. In a minor case can deliver vaginally also. If she is having hemorrhage, then we need to take care of the resuscitation part and accordingly manage. The list of the complications is many, and out of these, the most critical that has to be understood is occurrence of placenta accreta, particularly in patients who are having previous cesarean, history of previous cesarean or some major condition. So let's move to the other aspect of placenta previa. We are going to manage up as a complete case of APH, and we'll just revise it at that time. Abruption, we understand, is a complete or partial detachment. Complete usually happens in 7%, partial in 93%. More common causes is this. And if we go for APH, the perinatal mortality is very highly associated with it, and the fetus is affected to the similar degree or to a major degree. In these cases, more so often than in comparison to placenta previa, where the affection might be late. So we have various theories that have come up. The risk factors are lined up in front of you. The most important that I want to take up is that the history of previous abruptions is the most predictive. The remaining, as you see in front of you, you have certain ORs that have been mentioned. So those need to be paid attention. Then prevention as such, they say that prevention is better than cure, but you do not find any much action that you can take up in this particular aspect. Role of folic acid is not clear. Antithrombotic, if you take in, one study goes for that there is no use of heparin, low molecular weight heparin or aspirin, but other one has given some promising responses, because even the incidence of PIH was reduced and somehow the incidence was seen to be lower, but the study was small and therefore asked for a multi-centric study. Presentation, we all know that here in abdominal pain is very specific about. In addition to vaginal bleeding, that might be altered or less than what exactly has been bled. Uterine contractions are usually there, and there might be dizziness and various features of shock. So revealed versus concealed, we can have a difference between the two. Let's skip because we all are aware of the clinical findings as well. We all have encountered abruption so many times. A woody tense uterus, fetal heart, you have absent or distressed. Investigations are almost similar to what we have gone through in APH. Differential diagnosis go by in the same account. If we look for the management part, the fetus is alive and no fetal distress, you need to observe. If there is a sign of fetal distress, you might go for cesarean section. The fetus is dead, think about vaginal delivery, but in all times, we have to keep into mind that there might be DIC that might be developing in these patients, and coagulation profile is of significant importance. Then if we go by for, say, placenta previa and abruption, there's another condition that warrants mention, and that is vasa previa. Now, vasa previa, Madam has already told us in the previous presentation that it happens when the fetal membranes are having fetal vessels. The vessels can run by in two ways. These are the two types of vasa previas that can happen. Type 1 is filamentous insertion of the cord, where in the placenta, the cord is inserted at distance to the placenta. The other one is when there is a multi-lobe placenta and the membranes rupture in between. So these are the risk factors. The clinical feature of importance to remember that if there is APH associated with spontaneous or iatrogenic rupture of fetal membrane, there's no metal compromise, but fetal compromise is evident. Think about vasa previa. The of significance is that the baby compromises fast. So in addition to the investigation that we do in any case of PPH, the management will include a emergent cesarean section. If the condition is identified antenatally by the help of an ultrasound, which is having a good, say, pickup, because the false positive rate is very high and the pickup rate is much good. In such a situation, cesarean section can be planned up in an early pregnancy prior to any, say, evidence of rupture of membranes or any starting of labor. So the causes of APH are such in front, out of which circumvallate placenta warrants a mention. Since it has been covered, I'll not be going to the membranous, exsanguinate lobe, or multilobulated pregnancy, placenta. Let's come by to the summary. This is something that the features of how we differentiate between placenta previa, abruption, and vasa previa, that all we have. Then we have got various guidelines that give us of how to manage APH in these patients. And the basic principle we have already covered with. The 4 pillars of management, if we say, are the communication between the members of the multidisciplinary team, resuscitation, monitoring and investigation, and arrest of bleeding by arranging for the delivery of the fetus. So if we go by, it is an emergency and it has to be managed by a multidisciplinary team. Blood loss has to be estimated to its extent and appropriate correction has to be done. Call for help. Never forget this. The immediate action.
Thank you, Dr. Richa, madam.
The patient.
Thank you so much for your elaborate talk.
Madam, I am finishing up. So assessment
now
and then examination. This is the last step that you have to do is a stopping of the bleeding and be prepared for PPH neonatal resuscitation and do document, because that is very important. It is a very important cause of litigation that happens. Prevention also is better than cure, but once caught in bad situation, preparation and efforts matter. Thank you. With that way, I end up.
Thank you, Dr. Richa, for your elaborate and such a exhaustive talk. You really prepared it well, but because of the time constraint, we have to stop.
I understand. Thank you so much for bearing with me and giving me this much time, ma'am.
No. Dr. Aarti Kaushal, your comments, please.
Thank you so much, Dr. Richa. It was a very interesting talk, though hurried, but all the aspects, the management, the etiology, they were all very well covered, and we can go through all the slides and the flow charts in the recorded webinar.
Definitely.
Thank you so much.
Ma'am.
Thank you, Dr. Aarti. You are from Aurangabad, so I feel very nice. I stay in Nasik. So,
no, ma'am, I'm not from Aurangabad. I did my MD from Ahmedabad.
It is in Aurangabad. I read in the slide. Okay, whatever it is. Ahmedabad bhi apne paas hi hai. All India is ours. Thank you for gracing the chairperson, being the chairperson and giving your inputs. Thank you so much.
Thank you so much, ma'am. Thank you.
Thank you.
Thank you, Dr. Richa. Always, as always, Dr. Richa is another person that we always look forward to listening to in any webinar or in any panel. And but I'm sorry for giving you a little less time today to go through.
Okay,
but I think we'll hold another webinar.
It was very good
APH.
presentation.
Very good. Yes.
Thank you.
On APH, we'll have another.
Were absolutely research oriented.
Since we have many another important and very interesting panel awaiting, and we have wonderful I mean, the panel has been so nicely formulated by none other than Dr. Savita Singhal and Dr. Varsha Baste. Dr. Savita Singhal, we all know, is the professor, unit head, PGIMS Rohtak, and I don't think she needs any further formal introduction because she's absolutely an amazing person, human being, and a doctor, and a person who always anybody can look forward to for any help whenever needed for any patient in PGIMS Rohtak. And the second moderator, or the first moderator, I would say, is Dr. Varsha Baste, who is the chairperson and who was the chairperson of the FOGSI IAEC committee, International Exchange Committee, and she seeks your blessings and support, and she wishes that moving FOGSI forward and the newer horizons that she plans for us, for the FOGSIans, is her motto. So, Dr. Varsha, we wish you all the very, very best, and hopefully this 2023 is her candidature for FOGSI Vice President. So I'm sure Haryana is going to be a good support for you for your endeavor.
Thank you so much for Jyoti and Dr. All the panelists and all the esteemed faculties over here. Let me introduce the esteemed panelists over here. The dear friend Dr. Shashi Kabra, Dr. Ritu Jain, Dr. Monica Dalal, Dr. Pomila Malik, Dr. Priyanka Singh, Dr. Jyoti Malik, dear friend, beautiful, and Raju Mahendru. All of them are esteemed panelists of us, and they are going to take us in a roller coaster manner. They are going to dissect the placenta, and the placenta spectrum, Akita spectrum, is the important topic that we have selected, and with the help of our co-moderator, Dr. Savita, who is also the excellent academician, we have prepared the panel, and let us start the panel. So, Dr. Savita, would you like to share the slides, please?
Yes.
Friends, I'm going to contest. Yes, please. I'm going to contest for the post of FOGSI Vice President West Zone. We have to give 2 votes. The voting will start in August, but now I am in front of you. I am asking and seeking your blessings. Thank you. So we have, let me start the placenta accreta syndrome panel. Our esteemed panelists, I have told you, but I will again read their names: Raju Mahendru, Pramila Walik, Shashika Lata Kabra, Jyoti Malik, Ritu Jain, Priyanka Singh Mimani, and Monica Dalal. So the references we have taken are from ACOG Placenta Accreta Spectrum Obstetric Care in Consensus now, and from December 28, and RCOG Green Top Guidelines September 2018. And the placenta and types of placenta accreta. Can you highlight, Dr. Raju Mahendru, about the types of placenta accreta syndrome, spectrum, and accreta?
Good evening, ma'am, and good evening, ma'am, and namaskar to everyone present. Please pardon me for not switching on my video. So, as far as now we have come across from normal placenta to abnormal location of the placenta, now we'll be discussing about the abnormal placentation. So, PAS or placenta accreta spectrum is considered to be an umbrella term which incorporates that this placental, the placenta, how it is, say, attached to the myometrium. There it is directly attached to the myometrium without the formation of, say, either focal or the total absence of decidua, this basalis. And there is absence of metabox layer. So the chorionic villi or the trophoblast is directly attached to the myometrium, which may be total, which may be partial, or which may be focal. And the types of placenta previa are placenta abnormal implantation of placenta. This includes placenta accreta, This includes placenta increta or placenta percreta. So depending upon that, how much myometrium has been invaded by this trophoblast. And
Yeah,
the thing is that,
absolutely. So we have absolutely told us all the forms of placenta accreta spectrum. And how frequent is placenta accreta spectrum, Dr. Pomila Malik? Can you highlight it?
Yes, there has been one systematic study in 2019, which included around 5.8 million births. And they had about 7,000 cases of placenta accreta syndrome, which brings about a prevalence of about 0.17%. And
Yes.
this is very high as compared to what used to be there in 50s. And the prevalence at that time was 0.003. And I think the increasing incidence of cesarean, and most importantly, I think the way the cesarean is closed, the damaging the endometrium. We have to respect the endometrium and the myometrium whenever we are giving any scar to the uterus. So the incidence is definitely has increased in last years.
Yeah, so mainly it is iatrogenic, we can say that. And
it's basically a defective problem in the endometrium and the myometrium, defective decellularization and the replacement of myometrium by the scar tissue, which leads to the abnormal attachment of the placenta. The trophoblast invades the myometrium instead of having a normal decidual plate. And placenta accreta is the commonest, followed by placenta percreta and then placenta increta. The placenta accreta
so
is
Dr.
around
So Dr. Shashilata Kabra, can you highlight the pathophysiology of placenta accreta?
Yeah, thank you, Dr. Vatsa. Actually, it has partially been already explained by Dr. Promila.
Yeah,
basically,
I know.
It is a damage. It is as a damage to the endomyometrial surface of the uterine wall. So previously, the common causes were manual immunoplacenta, uterine curettage, endometritis. But recently, it has come up that the previous cesarean section, whether hysterectomy or cesarean section, that is one of the commonest cause. Actually, the pathophysiology is this, that there is absence of residue or Nitabuk's membrane, and in the absence of endometrial re-epithelialization of the scar tissue, the trophoblast and villus tissue invade deeply within the myometrium, and it also involves the circulation. That's why it is such a bloody situation, and it reaches sometimes up to the pelvic organ after crossing the myometrium and serosa. So that is the main pathology. So we have to prevent the primary cesarean section very much in prevention of placenta accreta spectrum. And there are many other causes like IVF. There are many.
Dr. Bhatia already told her about Nitabut layer defective development and all.
Exactly,
so
that
she
is
has
the
told
cause.
us micro reasoning of this
anything
problem.
which is damaging the endometrium, anything which is damaging the endometrium.
Yes. So what are the risk factor of this spectrum, Dr. Jyoti Malik? Can you highlight it?
Yeah. Anything which is damaging the endometrium or the decidua would be the factor, and previous cesarean is the biggest culprit. And as the number of cesareans increase, the incidence increases. From 0.3, it is becoming 6% depending on the number of cesareans that we are doing. Any uterine surgery, any myomectomy also, or any surgery, any scar on the uterus as such itself, multiple curetages or even a mid-trimester curettage can cause it. And multiparity, as the age increases also it increases. And very, very important, if there's a placenta previa, then 80% there is a chance. And if it is anterior placenta previa, then we should all be, our antenna should be raised, because that is very important cause of a pass. And nowadays, IVF and frozen embryo transfers are also in fact responsible for it.
Even manual removal of placenta, maternal age,
even bicornuate uterus, submucosal fibroid, many other causes. I would just like to add here one thing, that after a normal primary pregnancy, the incidence of placenta percreta is 3%. We can remember it like that way. After one cesarean, 10%, after two cesarean, 20%, and after three cesarean, 30%, and after 4 or 5 cesarean, 50%. Actually, it reaches up to 60%.
Yeah. I would like Dr. Savita to take the first case.
Yeah. A very, very good evening to the esteemed panelists, Dr. Jyoti, Dr. Shashilata,
Hello, ma'am.
And Dr. Varsha has discussed most of the things. But I just want to say, whenever we are doing our post-graduation in 80 or in 80s, there were hardly 4 or 5 lines in whole book of placenta acrita. We just told the definition and types, and we told the incident 1 in 5,000. Now see, over 20, 30 years. Now daily, I think no obstetrician can live that if he or she doesn't know the placenta, this pass. It is so common nowadays. With previous cesarean, yes, definitely. Any case, previous cesarean with low-lying placenta, unless ruled otherwise, you have to just take the suspicion that it may be placenta acrita, even if on ultrasound it doesn't say it is placenta acrita, but you have to treat the patient as a placenta acrita spectrum.
Absolutely right.
So I just want to share today's case only. Today I did one cesarean section in the morning. A doctor for a doctor with a doctor family. She's priming gravida, electric cesarean for borderline pelvis. She's priming. Just to my surprise, she was having placenta acrita. Whole of the placenta was adherent. I had to do the manual removal of placenta, and 2 cotyledons which are embedded, means it was placenta increta. That I had to remove in priming. Retrospectively, I took the history, why it was like that. There was no history of any evacuation, there is no history of abortion. But I just asked you, because one additional thing which I think can be there might be previous history of tuberculosis. Because these adhesions are there.
Yes, that's why it is called endometritis.
Book membrane and that, but she was not having any history of tuberculosis. To my surprise, still I'm trying to find out what is the cause in that small girl.
Ma'am, any IVF procedure?
No, no IVF procedure.
No IVF procedure.
Any
type of other endometritis?
Yeah, 2 lobules inside which were bleeding. I removed those lobules separately. Means it was placenta acrita with 2 focal placenta increta. That was
every pregnancy and every delivery is high
risk. For some time. Thank God, slight mild PPH was there, but not so extensive. Just as I opened the abdomen, full of big vessels, I couldn't take the pic. Then also I surprised why big vessels are there. Though the one thing which is placenta was just reaching up to the low uterus, just reaching, just at the edge of the main season. So in future, this is just rising, means we have to think over it. In future, some new cases might be seen with the primaries only. So this was the one today insight in this. So
yeah, ma'am, incidence is rising, in fact.
Yeah. To start with the first case, this is unbooked. This is my all cases which we're discussing. These are my cases which I dealt personally myself.
Yeah,
these cases
are all her own cases.
Yeah. I just discussed it 12 years back. What was the situation at that time? The patient was 34 years, gravida 5, para 2, abortion 2. And on color Doppler, she was diagnosed with placenta previa, placenta acrita. A posterior electric cesarean. At that time, 12 years, we were not so vigilant. We knew that placenta acrita is there. And there was not much of the treatments means defined. Now we know the defined treatment. If placenta acrita is there, we have to go for this. Otherwise, that time, so you can go for this, you can go for this. This was the things 12 years back. She posted placenta acrita was there, dilated vessels. I can show you the pic. This was the pic of that patient. Just opening this was the pic. Okay, for same patient. And what we did, because we are not so vigilant to go for the hysterectomy, though she already has 2 babies, but it was not such a common trend to go for hysterectomy. So we just followed delayed hysterectomy, and we did close the abdomen, didn't remove the placenta at all, and patient was discharged after 25 days. And we planned for a hysterectomy at a later stage, means that maybe after 6 to 8 weeks. We followed that approach in that patient because it's so vascular. We thought if we remove the placenta, she may bleed or die, but we're not in a lesson to go for the hysterectomy. So she readmitted after 6 weeks with secondary PPH and shock. Immediately in the emergency, we did the exploratory laparotomy. She had pyoperitoneum, whole the gut was adherent. At that time, we did the hysterectomy and we needed 7 units of PCV and 5 units of FFP. She shifted to ICU on inotropic support. She developed DIC. And she stayed in ICU for 4 or 5 days. We couldn't save the patient, and there was a mortality because, and the histopathology was proved she was a placenta infiltration into the myometrium. So what lesson was learned from that? So we learned that we should try for go for the, in these type of patient, we cannot remove the placenta. If we try to remove the placenta, definitely she is going to bleed and die. But if we leave the placenta in that can also lead to severe sepsis. So we learned the lesson that in these type of cases, not in all I'm saying, we should go for the primary hysterectomy. So for Dr. Ritu, so what is the principles of placenta accreta syndrome management?
Thank you, Dr. Savita. This was indeed an very interesting case. The first lesson learned that primary hysterectomy, and before we go for such cases, suppose we have diagnosed a case of placenta accreta spectrum on our ultrasound. Once it is diagnosed, we should decide the place of delivery. First of all, that should be a tertiary center where there is a facility for in-house blood facility should be there. The timing of delivery is also very important to avoid prematurity, to have a planned surgery at the time when the senior team is there. And it should be like senior obstetrician, 2 of them, 2 anesthetist, neonatologist, and urologist, neurosurgeon, I mean to say neurosurgeon, blood transfusion team. And we should have a very detailed, informed counseling in these patients before we go for procedure, because we also deal such cases in a way that we tell them each and every complications, right from the, depending upon what kind, if it is abnormally invasive placenta, then to the extent of, fistula, urinary tract injury to the parametrium,
yes,
and other structures, sepsis, shock. So very detailed counseling, and this thing for hysterectomy, arranging the blood, FFP, and the blood should be there in OT. The procedure should be done during daytime. That is very important.
There's a very big risk for the prerequisites.
Pardon?
Multidisciplinary approach and
yes, multidisciplinary approach, but the team should be and even if vascular surgeon is there or somebody, we should have a big team there. Everybody should be it should be done in day hours. That is very important. And then when we do this procedure, we can give antifibrinolytic at the beginning once anesthesia is there. Regional anesthesia, it may be extended to general anesthesia because it will take time.
For those questions.
And very important is that incision of the vertical incision can be taken up to open up the
we will discuss
abdominal cavity as early. And we should know the exact incision where we have to incise. It should be above the margin of placenta. Placenta should be untouched, even if we are doing a surgical approach, which is the radical approach. And once the baby is delivered, it is surgeon choice how rapid we can close the uterus, or else directly proceed on for hysterectomy. Other thing
main thing is Dr. Ritu,
we should be a complete hysterectomy rather than a supracervical hysterectomy, because most of the time it is the bleeding from the base. It is the complete.
Thank you, Dr. Ritu. We will discuss the procedure a little later on.
Okay. And the procedure, and the
main is these points to be
antifibrinolytic, we should, yes, and we should, very important while managing these patients is that we should have eye on the monitor also. Even the surgeon should have eye on the monitor, and the whatever decision should be taken, it should be taken with respect to time. There should be early decisions rather than delaying. And
more important, important. These are the important points. Then how should the patient optimize? Because we say the patient will be operated in the day times. So Dr. Priyanka, how could you optimize the patient? Dr. Priyanka is here?
Singh. Yes, ma'am. Thank you. Ma'am, that we should start as soon as we diagnose that she is having placenta accreta or placenta accreta spectrum. We should start the counseling to the patient that the problem is there. Your placenta is adherent, or it may be adherent so much that she may need the hysterectomy. So basically, maximization of pre-of HB value is very important. Proper counseling with the patient and their relatives is very important. We should tell them that the delivery has to be done in a tertiary care center where in-house blood bank is there, where in-house ICU, adult ICU is there, or the CCU unit is there, where in-house neonatal NICU is there, because we will plan the delivery at around 34 to 36 weeks. And before that, we should also tell the relatives and the patients that the risk of the delivery may lead to death of the patient also. So it has to be planned. It's not like that. Because
the consent is very important.
Yes, consent is very important.
We have to optimize by building up the hemoglobin.
Yes,
and just give an overview to the patient that these things can happen and decide the place of the delivery.
yes,
And
ma'am. We
these
have
are
to
most
tell the
important
patient that the
things.
place of the delivery is very important. I prefer
That is told prior hand.
colleges
Yeah.
or the tertiary care unit. We counsel that way.
Yeah.
So, and this is a pre-operative. Intraoperative, Ritu Jan ma'am has
Intraoperative
already.
we will discuss later on, Dr. Priyanka. We're just discussing that. Okay, for Dr. Monica, what's your timing of delivery? Like Dr. Ritu has just explained the timings also. Dr.
Yes,
Monica is
ma'am.
here?
Yes, ma'am. I'm here only. So in this patient, we want to plan for the elective cesarean section rather than patient landing up in emergency cesarean section. So while planning for the timing of delivery, we need to have a balance between maternal risk and benefit and fetal risk and benefit. So ACOG has given a window period between 34 to 35 plus 6 weeks of gestation. So we need to see that whether patient is a high risk for prepartum hemorrhage. If patient is a high risk for prepartum hemorrhage, like patient is having recurrent episodes of antepartum hemorrhage or had premature rupture of membrane or had history of contractions, then we will plan the cesarean in these patients slightly early at around 34 weeks. But if patient is not such a high risk for going into prepartum hemorrhage, then we can plan later on, near 35 plus 6 weeks. So we need to see individually that whether when we should plan between, but there's a window between 34 to 35 plus 6. After 36 weeks, there's a high risk of patient landing up in emergency cesarean section.
So yeah, very well told, Dr. Monica. There's a main two things are there. One is whether it is going to increase. Like in few cases, if already one case we operated on 32 weeks because already bladder invasion was there. At 30 weeks, bladder invasion started. And then what we thought, Dr. Monica must be remembering that patient.
Yes, ma'am.
That I told that it will keep on increasing. So we didn't allow that patient to go beyond 34 weeks, even in between 32, 34, 33 weeks, I did the cesarean section for that patient. Because that is also one important point. If it is a percreta type, invading the surrounding areas, then we may have to do little earlier. If it is only the accreta, no percreta is there, then we can wait till 36 or 30. It is definitely not beyond 37 weeks, any patient. And I would like to say not beyond 36 weeks in any case, but 34, 36 is the window. Dr. Rajiv Mahendru, you're having so much experience, just we will like to share your experience about the cesarean sections and the prerequisites of cesarean and the procedure of cesarean while for doing the cases of placenta accreta. Can you hear me?
Yes, Dr. Rajiv.
Many
Please
of the
talk
things
loud.
have been covered. Many of the
Can you
things have
little
been
higher?
covered.
Your volume is not.
Ma'am, am I
Yeah,
audible
now
now?
Yes. So you have to little bring your mic near to you, mobile.
Okay. Sure, ma'am. Actually, many of the things have been covered, but timing and consent has already been covered. And we should carry out in a tertiary care hospital where blood bank facilities along with the components should be available. And we should take up the patient under general anesthesia or epidural. And midline incision is preferable. Rather, it should be mandatory for the cesarean to be carried out in such patients. And then we should have a urologist. Besides all those senior people team, we should have a urologist also available with us.
I
As
think
you have
prerequisite
said.
Dr. Ritu has discussed very well. Yeah.
Yeah. During cesarean section, we should give the incision above the level of the upper margin of the placenta, and we should not try to disturb the placenta. And if there is bleeding, then we can use the balloon tamponade or something. And I was going through the literature, though I haven't got any experience on that, but people have mentioned that systemic or intra-umbilical administration of methotrexate also to reduce the bleeding in such a case. So there are instances of the cutting of the cord. If the placenta is firmly adherent and it is not bleeding, then cutting the cord flush with the placenta and say wait for aseptic autolysis or regression of the placenta, though it is also say not devoid of any risks, because as we have already mentioned a case that went for purple sepsis also, and delayed PPH can be there and delayed hysterectomy it can lead to. So these are the things which should be taken care of. And bleeding, of course, one should be very particular and interventional radiologist, if available, can be considered in that for the UAE also
Yeah.
in the cases.
Yeah, very well. So we have to take care of the bleeding. So before doing the cesarean, we can go for these internal ligations or these embolization and yeah. Over to Dr.
So I will
Das.
take the case wiser, and now we have become more wiser and smarter. So let us discuss about case number 2. She was an unbooked patient, 26-year-old, G6, P2, L1, A3, long obstetric history, 35 plus 6 weeks, referred for placenta acreata with history of PV bleeding. On examination, her obstetric history tells us that she had undergone both vaginal deliveries, and curettage was done for 3 miscarriages. Sonography said central placenta previa, 35 weeks. Placenta acreta was diagnosed, and so now how to deal with her? She is bleeding profusely. So she was shifted to OT. Preoperative findings were engorged blood vessels over anterior half of uterus and left posterior wall. Emergency classical C-section was done. Placenta covering was and placenta increta. Intra-op shock was managed. Cesarean hysterectomy had to be done. She needed 5 PCV, 6 FFP, and because he bled 2 liters, and post-op was uneventful. Discharge on 8 post-op day, and baby was healthy. So next. So now approach for cesarean hysterectomy, how it will be, Dr. Pomila Malik.
I want to add on one thing, that this patient was referred in middle of the night at about 2 a.m. by a private practitioner with such a profuse bleeding. So that is the importance of optimization and earlier admission. If the diagnosis is made
this
earlier,
patient should have been
it's a
referred
lesson
earlier.
for the standalone practitioner, they should refer prior.
Yes.
As soon as the placenta accreta or any patient with placenta previa and previous cesarean, I think should be referred to the higher center so that this delay and this morbidity is not there for the patient.
One more thing I would like to add, if somebody at peripheral center has opened the abdomen and found a placenta percreta or accreta, then better, if it is not equipped, then better close the abdomen and send the patient in that condition to
Don't touch it. Close
Don't
it and
touch it.
send it refer.
At least to save the mother.
Yes.
And this patient, she didn't have a cesarean, but because of the previous curettage, she had this placenta accreta syndrome in her case. She had normal deliveries, but because of 3 DNCs, she had placenta accreta. And this patient, once she was diagnosed as placenta accreta, she should have been referred earlier for an elective cesarean. And in case of
nowadays, sonography can diagnose it very well.
The placenta previa was diagnosed at 21 weeks.
Yes.
Okay. So she should have been referred so that this poor condition should have been avoided.
Antenatal, as antenatal management has already been described, the correction of anemia maybe by giving IV iron is very important. And if the patient needs to be delivered earlier than 32 weeks, magnesium sulfate coverage and antenatal steroid coverage has to be given. For a cesarean, now it is mandatory that placenta accreta syndrome, we have to go for a peripartum hysterectomy. The conservative management has been described, but with lot of complications. So the standard protocol is go for a peripartum hysterectomy, and it has to be done in a tertiary center with the blood bank facilities, multidisciplinary with a urosurgeon and plus a vascular surgeon also, and preferably with the interventional radiologist, in which the uterine artery catheter is already there in the uterine artery and the internal iliac artery. And once the baby is delivered, they put a gel form or they inflate the balloons. And even Dr. Pelly had number of cases. He has developed a aortic clamp, which he has used, and he has said that he didn't even require blood transfusion in cases of placenta accreta syndrome while he was operating, doing a hysterectomy for this thing. In doing a placenta,
so that clamp is also a must nowadays with on our OT table.
In planning this thing, the anesthesia has to be a general anesthesia. Incision has to be a midline vertical incision. And then we we give a midline vertical incision in the uterus in the upper segment, at least 3 fingers above the upper edge of the placenta, so that the placenta is not disturbed also while we are delivering the baby. And after delivering the baby, cut the cord, leave it as such, quickly close the hysterotomy incision, and then proceed with the hysterectomy. And then
Yes,
if the
Dr. Shashi, Dr.
one
Shashi
more
Latha
important thing
Kabra.
is
These are
one more
important
important
points in hysterectomy. We have to take care that the clamp should be applied not just near to the uterus. Otherwise, they can poke inside and can lead to bleeding.
And one
This
more
is very
important thing is we don't give any oxytocics after delivering the baby because they may start separating the placenta. No oxytocic has to be given. While we routinely do the active management of third stage, in doing this, we don't have to use any oxytocics.
Yeah.
So we have to
What
dissect the
problems
bladder
you
prior.
anticipated, Dr. Shashi Latha Kabra?
Yes, Dr. Varsha. The main problem with placenta perpetuita spectrum is bleeding. Patient may bleed up to 2 to 4 liters of blood. The first thing, as she has already told, that we have to make an incision above the boundary of the placenta perpetuita. Then what I do, I am sharing my own experience because patient bleeds profusely. So before performing a hysterectomy, I do a bilateral internal iliac artery ligation. And by doing an internal iliac artery ligation, the bleeding when we are performing hysterectomy, the standard treatment for placenta acquita spectrum is cesarean hysterectomy with placenta in situ without attempting to remove the placenta. So when we do a bilateral internal iliac artery ligation, then we perform the hysterectomy, the bleeding is reduced. And if the bleeding is reduced, then the chances of ureteral injury, bladder injury is also decreased because our operation area becomes more visible. And the other problem which we face during peroperative is while we are performing internal iliac artery ligation, there are chances of injury to other bigger vessels, external iliac vein, internal iliac vein, that will learn only by expertise. Then bladder may be adherent. If bladder is completely adherent, I would advise to go by lateral window, and it is always easier. And if we feel that there is an invasion inside the bladder, then it's better that we call our urologic or surgical colleague. And sometimes we should not fear for doing a cystostomy rather than opening the bladder, rather than making more complications. And then usually in my cases, I have not seen much of bowel adhesions. But if bowel adhesion is there, placenta has gone up to the pelvic organs and bowel, take help of a surgical colleague and get them dissected properly. So that is the thing. Still, and in the multidisciplinary approach, and we should take the consent from the patient beforehand that these things, bowel injury, bladder injury, chances of blood transfusion, ICU requirement, and all these things will happen. So basically, it is a multidisciplinary approach. Everybody has told about this, but I would like to add one thing. It is not only multidisciplinary, the senior-most faculty of each and every discipline should be present there. That is the most important thing. So, ये case morning में अच्छे से लगाना चाहिए. We should avoid doing this case in evening and afternoon, better in morning hours with all facilities available.
So very well explained, stepwise.
And
main thing is don't be panic at all. If you know the stepwise approach, minimal bleeding will be there, minimal complication will be there. Preparedness is most important, and no panic. You should know what are the steps.
And if it is perpetuita invading the bladder, preoperative ureteric stents can also be placed if they are.
Yeah, I would like to add one thing about this. The RCC guideline says that the placement of preoperative stent is not a routine, but if there are already a preoperative diagnosis of bladder invasion, then we can put a stent and we can do a cystoscopy also. That will be preferable.
Yes.
Yeah. So coming to the next case. It is a case like that. You are doing the elective cesarean for placenta previa, okay? And findings are like this. And what these findings are suggestive of? Dr. Jyoti Malik?
I think this is absolutely, one should be ready and prepared that this is a case of placenta perpetuita syndrome because we are getting such engorged, dilated, angry looking vessels covering the lower uterine segment and extending upwards. So we should, without touching and without opening, we should first get ready with everything, with our anesthesia team, with our senior, another obstetrician, gynecologist, urologist, and everybody should be there. And we should have extra IV lines there. We should order for blood and arrange blood. And then if we are caught unaware, first talk to the attendants and tell them that this is the finding and we will have to remove the uterus to save her life, because this is what we are anticipating, seeing the superficial only on opening the peritoneum.
So if this type of picture is there on opening the abdomen, so always think that it is a case of placenta.
But if you are not in a tertiary center and you can't arrange everything, I think it's better to close and refer her to the tertiary center.
Okay, Dr. Ritu.
We are there on this.
Suppose you are a standalone practitioner. I am just saying you are a junior most doctor. Just imagine you're junior most doctor there. or you just started your practice, I will say. You just started the practice and you open a case like this. What you will do now? Means you are a standard practitioner, only one nursing home is there, and this type of patient is with you. You
Most
just
of the
open the abdomen. What is to be done now?
See, Dr. Savita, this thing would happen if we don't have, if it has happened accidentally, suppose we
Yeah,
have
yeah. I
taken
am
a
saying just you are caught unaware. Means you just
No,
open the abdomen.
we
for
just,
placenta
I will
previa.
just close the abdomen and I will shift the patient to a tertiary center where I am attached and where everything is there.
Absolutely.
Absolutely.
Yes.
Team, multidisciplinary team with ICU, NICU, and blood bank facility with all my other colleagues from all the departments. And there I will post this case. I will explain the whole situation to the attendants. I will take a detailed informed consent. I will tell them the need for primary hysterectomy vis-a-vis the alternative of delayed hysterectomy and its complications are, they are too much. So it is better for a primary hysterectomy. And then the triple P approach, of course, doesn't, fit in here where such a situation, urologist has to be there. And having
if you are a standalone practitioner,
in between, if it is possible, I may do a perioperative ultrasound also. Otherwise, I will take incision above 2 to 3 centimeter above the suspected margin of placenta, deliver by vertical classical cesarean section, and having delivered, again I will proceed for hysterectomy. I'll have blood and FFP in OT depending upon what the coagulation profile of the patient is, and immediately I think the steps have already been we have taken, and it will
be. Yeah, Dr. Ritu, if you are a standalone practitioner, so lesson you very well said that you will just shift the patient to higher center after closing the abdomen.
Yes,
abdomen.
And explaining
but
them the
someone
whole
has
situation.
to accompany the patient. Someone has to. This is the most important. Someone has to accompany the patient. Maybe your OT nurse or maybe some OT technician. And counseling is to be done prior hand. Sometimes you may take the pics also. For
effective communication.
You can take the pics before referring the patient. Okay. Sometimes you're another situation for standalone practitioner.
May I add one thing, ma'am, in this regard?
Yes.
Yeah, once we received a patient who was opened in peripheral place and later patient reached to us after 4 hours. So the one important thing before sending the patient, it is very important, then one must recognize that this is a placenta percreta. Those people who can't recognize that this is a placenta percreta, they accidentally open it. So that is also very important. Recognition of placenta percreta.
Slide. Yeah. How can
yes, that slide is very good, ma'am. Yes, exactly.
This slide, everyone has to go through this. If these findings are there, typically repeat cesarean section, placenta tissue, the tortuous vessel, always think it as a placenta percreta. Means this type of picture is there. Yes. So then you should refer the patient. And if same condition, you delivered the baby. And once you delivered the baby, then you say that you cannot remove the placenta at all. And it's such a tortuous. What is to be done? Dr. Priyanka?
Ma'am, it has happened with me once. We have delivered the baby and placenta could not come out. So we could recognize it as early. So we did not try to pull the placenta. I just packed the uterus that time. I told my anesthetist that this is a problem. The placenta is adherent. And after packing the uterus that time, I just told my assistants and I called my husband, he's also a doctor, so that to call surgeon and arrange blood. So we did not start the hysterectomy before blood could come. And in the meanwhile, I had explained to the relatives that this is the situation and we have to proceed for the hysterectomy. So we did the hysterectomy with the senior surgeon along, and we could save the patient.
So never hesitate to even close the uterus and then refer the patient. If you're not having the has to be done. Small setup is there. Small setup is there. Even this RCOG says you can close the abdomen or you even close the uterus also after delivering the baby, so that you are able to save the life of the mother.
Right.
Very well said, Dr. Priyanka.
Thank you.
So if some adherent lobe is there only, so it's a partial, means lobar. One lobe is adherent, how to proceed then? Means you have removed most of the placenta, only 1 or 2 lobes left. Is there some role of methotrexate, Dr. Monica?
Yes, ma'am. For understanding the role of methotrexate, first we have to understand the mechanism of action of methotrexate. It acts on the rapidly dividing cells. And in third trimester, cells are not dividing that rapidly, and their rate of decay is
Yes,
very low.
absolutely.
So and further, there are so much of side effects of methotrexate, especially nephrotoxicity and hematologic toxicity. So when we weigh the benefit versus harm, so harm is more rather than benefit. So its use is not recommended.
Yeah, so
Excellent, Monica.
most of guidelines say there is no, it is not recommended to give methotrexate. Okay. So Dr. Rajiv, what are the ultrasound findings? You can just explain in the.
Ji, ma'am. Ma'am, the ultrasound is a very important tool as far as diagnosis and planning for further management of this placenta or abnormally adherent implanted placenta is concerned. So one even grayscale, 3D or color Doppler, all of them have got their own importance. So one is that there is a loss of sonolucent layer or clear zone between the placental bed and the myometrium. Thinning of myometrium, that is retroplacental site less than 1 millimeter, and intraplacental lacunae are there. Loss of hyperechoic line between the uterine serosa and the bladder interface, that is missing. Placental bulge or exophatic mass invading the uterus towards the bladder. That is also one of the signs. And as far as color Doppler is concerned, hypervascularity between myometrium and posterior wall. And as far as International Society on PASS is concerned, they have given the scoring to the ultrasound findings. They have carried out 10 points, and total scoring 0, 1, and 2 is given, and total scoring is 20. So the points they have taken are placental lacunae, hypoechoic retroplacental space, as I've already said, myometrial thickening, uterine bladder interface. These are all the points which are taken into consideration, and scoring is being given. And based on this scoring, total score is 20. And when the scoring is there, then one can devise the further management for such a case. And it is said that if carried out keenly by a good sonologist, this also even MRI is not required in such a case if we carry out the ultrasound very clearly, very keenly.
Yes, very well explained that ultrasound itself is sufficient for the diagnosis. You do 3D ultrasound, 100% sensitivity and 85% specificity. There still the clinical risk factors are the most dependent one. I just explained that any patient previous cesarean low-lying placenta, even if ultrasound says there is no placenta accreta, we should treat the patient placenta accreta. Last year, I just find out 6 cases of placenta accreta syndrome, studied their reports. 3 patients were proved by the ultrasound as a placenta accreta. They didn't come out to placenta accreta. And the patient who were termed as placenta accreta, came out to placenta accreta. So unless ruled otherwise, you should treat the patient as placenta accreta spectrum. And what is the role of MRI, Dr. Pomila?
One thing I wanted to
role,
add
because it is sufficient enough, but still in some cases we say we should go for MRI. So what are those patients?
In ultrasound, I just wanted to add one thing. Any patient with a previous cesarean, the ultrasound should be done at 5 to 7 weeks to know the location of the gestational sac, whether it is implanted in the cesarean scar or not. Because cesarean scar pregnancy is supposed to be the precursor of placenta accreta, so that we can diagnose the precursor of placenta accreta in very early stage at around 5 to 7 weeks also. So that's what about it.
Very well said.
In early stage.
Very well.
And MRI, as already said, the sensitivity of a ultrasound done with a transabdominal combined with a transvaginal and Doppler, the sensitivity is as high as 95%. So the role of MRI is very limited, and in very few clinical scenario, especially in a case of a posterior placenta accreta, in which the patient has undergone a curettage or a myomectomy, in which we are suspecting on ultrasound that it may be a placenta accreta, because we don't have the bladder to see the bladder line and this thing, differentiate between the myometrium and the bladder line. In that case, we need to get an MRI, and in the patients who are having placenta percreta, to know the depth of the invasion into the bladder. We have to see that. And thirdly, we have to know the extent of placental invasion in the lateral part of the hysterotomy, because that cannot be very clearly seen with an ultrasound. And the findings are almost similar. There's a loss of the clear zone behind the placenta, thinning of the myometrium is there, and the bladder line is also disrupted, and there may be a exophytic mass inside the bladder also if it is a placenta invading the bladder.
So yes, very well explained that for not for the diagnostic purpose for the placenta previa, but for the extent of the invasion.
And it should be done around 24 to 30 weeks. Not
so now we are very short of time. We are already it's past 6. We will quickly take this case 4. She is unbooked case, 27-year-old lady, gravida 2, one living child, 33 weeks, previous history of cesarean. Multiple bleeding episodes. She is giving the history. Sonography tells placenta previa covering the os, no accreta, and she has IUD. So she came with PV bleeding in shock, shifted to OT, and then emergency laparotomy was done, and preoperative placenta previa type 4 percata with bladder wall infiltration was diagnosed. So emergency classical cesarean section was done, hysterectomy was done, partial bladder wall also resection was done. Hemoperitoneum 2 liters, 5 PCV, she received 4 PFFE. And post-op ICU for second, she had UTI on day 8. Then rest was uneventful discharge after this removal of SRC after 3 weeks. So steps to avoid urological injuries. Dr. Shashi Lata Kabra, you can tell us very well.
Dr. Varsha, thank you so much. So the first thing is that the incidence of urinary tract injuries around 30% unintentionally in a case in such cases. Now out of this, 80% occur in bladder and 20% in ureter. Now stepwise, first thing is that we have to try to keep our operative area little less bleeding, so that we can recognize the bladder, we can see the ureter. So for that, I had already told that we have to perform a bilateral internal iliac artery ligation earlier, so that bleeding can be reduced and we can use Gris-Marvites forceps. Second thing, if bladder is adherent and we need to do dissection in lower part, then we can partially fill the bladder, and that makes the dissection easier. And we can call our surgical colleague. Third thing is that if on pre-operative MRI and USG, if there is already significant bladder involvement, then we can put a pre-operative uterine stent and can do a cystoscopy also. Fourth thing, that if at that time there is massive placental adherence in the bladder, then better open the abdomen, open the bladder, cut that part of bladder which is adherent with the placenta, and then resuture the bladder and reform the bladder. That is much more safer than causing multiple injuries in the bladder. This is for bladder. Now for ureter, opening the retroperitoneum is must. By opening the retroperitoneum, you will get 2 advantages. One thing, you will get an opportunity to ligate the internal iliac. Second, you can see the whole pathway of ureter. So you can always save the ureter. Ureter lies in the medial flap. So you can always recognize it and you can push it on the medial side. And this way you can save the ureter also. So these are the few
What are
things.
the complications of surgery, Dr. Jyoti Malik?
Yeah. So the complications could be any, Dr. Varsha. It could be injury to the bladder, to the ureter, or if the placenta is adherent, it could be injury to the gut. And there is, because there is extreme blood loss, it needs massive, the surgeon needs to be constantly knowing how much blood loss is there. So the anesthetist has to be sort of anesthetist and the person on the floor and the surgeon. They all have to be on the same platform, knowing what is happening, so that accordingly the blood transfusion can be ordered and things can be taken care of. The patient can go into hypovolemia, she has to be kept warm. So those things, the output, urinary output, then they have to also send all the blood parameters intra-op. One has to take care of the prothrombin time, APTT, fibrinogen levels, the electrolytes, ABG. So all those things also need to be done simultaneously.
Thank you. Next. So we will stop now because we do not have that much time. Can you wind up, Dr. Savita, please?
Okay. So this was also an interesting case. Just in one line, I can say it was diagnosed at early pregnancy, miss. She was 12 to 13 weeks, and we just had to land it with, she landed up with a hysterectomy at 12 weeks due to this placenta. I'm just passing this case. Okay, so just the take-home message is that suspicion or diagnosis is most important, and we have to be vigilant in patients of placenta previa with the previous cesarean section. And in small setup, we can refer the patient, don't hesitate, even after opening the abdomen or after delivering the baby and closing the uterus. But before referral, as well explained by the esteemed panelist, very well told that we should be in touch with the referral institute and take precaution that we should telephone them up earlier that such and such patient being taken there, so that they keep ready blood and inform the patient, take few pics of the condition to avoid the medical legal, and just tell what can happen there, and accompanying with the patient you must in case of referral. If caught unaware, again, do the careful planning. Forcible removal of placenta should never be done. Termination, 34 to 36 weeks. Never take beyond, though we say it can be taken 36.6, but I say don't take more than 36 weeks of pregnancy because fetus is well mature by that time. Counseling regarding the recurrence in next pregnancy if you are not doing the hysterectomy. But now we say cesarean hysterectomy is the best option. Don't conserve the uterus to save the life of the patient. And inclusion of the multidisciplinary team, that it must, urologist, general surgeons, and our intensivist, and then no role of the methotrexate. So thank you all.
Thank you, esteemed panelists.
I'm
Raju Mahen,
yeah.
Malik, Shashilata Kabra,
Ritu wants
Jyoti
to say
Malik,
something.
Ritu Jain, Priyanka Singh, Mimami, and Monica Dalal. I would like to thank you all because you gave such an excellent explanation and gave your inputs, and really the standard was very high. The cases were exam selective, only the time was less, so we couldn't justify, but all in all, it was a fantastic, brilliant panel, and I am really thankful to all the panelists and captive audience. Thank you so much for being here. I'm really happy for having me here and giving me the opportunity to talk in front of this August gathering. I'm really thankful to this Haryanvi audience and Haryanvi, Dr. Jyoti Malik and Dr. Ragini Agarwal, who helped me arrange this webinar very well. Thank you so much. And I'm thankful to Shield also for giving the pharma support.
Dr. Ritu wants to add.
I would like to say
Ritu
one
wants to say
very
something.
important
Yeah,
thing
Dr.
that
Ritu.
one very important thing that the senior team, say the vascular surgeon, neurosurgeon, anesthetist, and senior obstetrician, we should have number in our phone. We should call them, because if you ask XYZ, your OT technician, to call, the impact may not be the same, and they may not understand the gravity of situation. You have to call either yourself, somebody can call, the number should be displayed in your OT, they should be with your staff, and your communication has to be very effective. If you don't call, they don't understand the urgency. Somebody may be going home, you have to call back when you are caught unexpectedly.
Absolutely.
In fact,
absolutely.
in small towns,
Every delivery is now high risk. We have to be prepared for each and everything.
In small towns, you can have these sort of teams, people who are experienced, who are expert in internal ligations. So immediately they can come to your rescue if you are caught in such situations. Where in small towns, if the patient, if you can't send the patient to level 3 or 4 centers, and if you are caught, then you should be having such teams there in your own city who you can call and they can come to your rescue, I suppose. Yes. Dr. Shashi.
Yeah, because the incidence of placenta acquita spectrum is rising. So I think every obstetrician must be trained and now must learn the art of doing a complete hysterectomy, obstetric hysterectomy and internal artery ligation. Iske bina kaam nahi chalega.
Dr. Mitra is doing a wonderful job. Dr. Vibha Dua, would you like to say something, please? Madam, you have to unmute.
Unmute.
I wanted to ask about triple P procedure. during operation.
Triple P is perioperative placenta localization to know the upper margin of the placenta. Then it is pelvic devascularization, that is internal iliac artery ligation bilaterally, and or if the baby has been delivered, do a embolization, internal iliac embolization or a uterine artery embolization, and followed by a removal of the placenta and the myometrium, where the placenta is this entire thing. Delivery, if the baby is delivered by a transverse incision, the entire placenta with the myometrium is excised, and then the uterus is repaired. That is why it is known as triple P.
Ma'am, this is a conservative procedure.
Yes, it is not recommended.
Madam, it is a conservative procedure and better try to avoid in our situation, our
Yes.
country situations. The
It's only
standard teaching
experimental
is
studies are being
experimental
done.
study. The only
Yes.
standard teaching is cesarean hysterectomy with placenta in situ.
Peripartum hysterectomy. I just
One
wanted
more,
to add one thing, that do you think that the way the single layer closure has been this thing advocated since, that is also responsible for the increasing incidence of placenta accreta? Because what we have found when we were closing it double layer, the myometrium, when we opened it again, it was a very good, very well healed scar, like a primigravida, what I have opened my cases. But since the single layer closure came, it was just totally defective myometrium. And defective myometrium
But say that nowadays
decellularization is one of the
you
important
should close the
causes.
uterus in 2 layers.
Yes,
to
no.
avoid these things.
Because majority are blaming increased incidence of cesarean, increased incidence. That is okay.
Ma'am, that is.
But I think the way it was recommended that do a single layer closure, and it had been there for almost 1.5 or 2 decades, and it leads to a very defective scar. Only it is just covered with the peritoneum. There is no myometrium. Just a scar is covering the previous one. So there are
no evidence-based trials.
There may not be any evidence, but it is the basic pathogenesis is defective decidua and defective myometrium. The basic pathogenesis of placenta accreta is that. There may not be any evidence, but I think that is a very, very important cause. That proper. We should have a proper.
Vibha Dua, do you want to say something, Dr. Vibha Dua?
Yeah.
Yes, madam.
Yes. One more query. Dr. Pramila, you said that we can diagnose placenta accreta at 5 to 6 weeks,
Yes,
7 weeks
it is not a
gestation.
placenta
But-
accreta. It is known as a cesarean
scar pregnancy.
Yeah,
So
you
that is
said
a
na, if it
precursor.
is, I know that. If it is a cesarean scar pregnancy, will you like to continue her pregnancy?
That
You won't like to
decision-
terminate?
that is a totally a shared decision between the patient and the this thing. See, if she is very much willing to continue the pregnancy, you have to counsel that it is almost 99% going to land up in placenta accreta, and then you have to take at that very stage you have to take an informed consent about all the possible things, that she will need a peripartum hysterectomy, delivery in a tertiary center, require blood transfusion, and all the other injuries and all. We have
Thank you, esteemed panelists. We are running short of time, and this is a never-ending discussion. Thank you so much. I'm sorry I have to interrupt because the time is the audience also. We have to take care of the audience also. Thank you so much for being here. And really thank you for having me here. And also,
all the
really
best,
thankful
Dr. Varsha.
for each of you.
All the best, Dr. Varsha.
All the best, and thank you for inviting us as panelists.
My special regards to Savita Singhal, ma'am. Ma'am is a great academician.
Thank you, Dr. Savita. Very well moderated panel.
Lovely pictures, and absolutely we walked through the OT, I think.
Excellent moderation of the panel.
Absolute placenta को हमने पूरा समझ लिया अंदर से बाहर तक. Increta, percreta, physiology.
अरे सारी obstetrics placenta के around rotate करती है. The entire obstetrics.
Thank you so much, our participants.
The recording will be available immediately after the webinar, so don't worry. Everybody is asking me.
Thank you, participants. All this recording will be available, and we will put it in the Her Obgyn social groups and also other groups wherever you are, and we'll definitely reach out this recording to you, because it was a lovely session that we had today. And thank you, Dr. Rajiv Mahendru sir. Dr.
Rajiv, phone number batao aapka. 2 people have asked about Dr. Rajiv phone number.
Sir, आप please type करके chat box में अपना number डाल दीजिए.
Yeah, that's better.
Yeah, and Dr. Shashi Dr. Pramila, Dr. Monica, Dr. Ritu.
Someone wants all the panelists' phone numbers, so they like the panelists also talking so much. Very,
So
relevant talk.
Shield
I
can
think we have to
them.
go a long way still for the mystery of this pass. This scar pregnancy, single layer, double layer, so many things are there. We have to just think of, and some new things may arise after 5-10 years.
We have to have a uniform protocol for
what we are talking
the
now.
uterus.
Right. So,
on behalf of the organizers, I am
thank
thankful
you so much
and
to
I'm
Dr.
thankful to the
Ruby and
panelists.
Dr. Richa. Dr. Ruby and Dr. Richa, they were extremely, their lectures were too good. The chairperson, Dr. Mitra, we missed you. But Dr. Renu Chuk, Dr. Aarti, Dr. Poonam Lumba also, she could not join. And our guests of honor, Dr. Vanna, Dr. Vibha, thank you so much for joining. Dr. Ragini, you are always there to inspire us and to guide us and to give us such wonderful occasions where we can learn and learn and learn. And thank you, Dr. Varsha, for giving us this, for stimulating our minds and
platform.
For
Thank
giving
you so much. I'm really obliged and overwhelmed by the love, affection, and the fellowships. Thank you.
Thank you.
All
the best. And thank you.
Mast log hai. And I made many friends also. Thank you so much. Hi. Love you all.
Bye. Thank you, Shield.
All the best, Dr. Thank you, Jyoti.
Thank you, ma'am.
And Savita.
Thank you, everyone.
Bye. Love you, Jyoti. Thank you.
Bye to all.
Bye.
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 Thank you.